I think we are ready to start, Dr. Krager.
Welcome to the 8th Top to Toe Transcatheter Solutions Conference that is being held in Dubai and virtually worldwide. The organizer and program director have asked me to join as a co-director of this very unique meeting that's being held for 8 consecutive years. I met with Dr. Omar Halak 9 years ago at Arab Health, and he was also organizing the education component of Arab Health in Dubai at that time. And we had very similar ideas, 2 similar ideas on 2 different continents, to organize a meeting in Dubai and United Arab Emirates that will be unique in a way, consisting of joining all the specialists that are involved in endovascular treatment of cardiovascular diseases. That did not exist at that time in that area of the world. I was at that time one of the leaders in the International Society of Endovascular Specialists, and our motto was to work together with all the specialists in the field of endovascular medicine. The society was initiated by Dr. Edward B. Dietrich, and I was shortly after that became a president. So it is unusual for a multi-specialty type of a meeting that embraces all the specialists in the field to join together to bring to the educational forum our experiences and share our views and expand camaraderie between the societies. Dr. Omar Halak has a tremendous influence in that part of the world, and I consider him a great friend and partner in this field, and I would like to welcome him with his introductory remarks.
Well, thank you, Dr. Krager, for the introduction, and I'd like to welcome all of you. I'd like to start as a Bismillah ar-Rahman ar-Rahim, ladies and gentlemen, friends and colleagues, distinguished guests. It's really my pleasure to welcome all of you for the 8th Top-to-Toe Transcatheter Solution Conference, 40S International. My name is Omar Halak, and interventional cardiologist and the head of cardiovascular department at King's College Hospital, Dubai. Due to COVID, as all we know, with a lot of restriction worldwide for travel, we elected to have this conference this year as a virtual. I hope next year COVID will be things of the past, and we have all of you here in Dubai, our guests, enjoy this beautiful city and actually beautiful weather in February. As Dr. Krager mentioned, more than 8 years ago, we met and we kind of start the idea of putting all things together of cardiovascular system, because we thought that there's different people doing different things for the same artery. For carotid, for example, I mean, interventional cardiologist, interventional radiologist, vascular surgeon. So we thought about putting a program together. We have everybody involved in vascular system to get participated, and we share all the knowledge, skills, and cases. It has been a very successful meeting for the last 8 years, of course, with partnership with a lot of wonderful colleagues and friends from Emirates and from around the world. And of course, Dr. Krager was a really a great partner for this meeting. He spent a lot of efforts and time to ensure the success of this meeting. Now the 40S became one of the largest interventional cardiovascular conference in the whole Middle East. I'm very happy and delighted to have more than 100 speakers, eminent speakers this year from around the world. They're going to bring to us the latest in cardiovascular field. They're going to share with us their challenging cases and interesting cases and give us a unique opportunity to learn and have a wonderful time of discussion with those cases and the way different part of the world dealing with those cases. I'm also delighted to inform you that we have more than 2,000 participants this year in this conference from 63 countries. This is really very pleasant to all of us. And I hope that next year we'll have all of you here in Dubai and we enjoy together this educational feast and also enjoy this beautiful city. The conference we start usually with a session called Latest and Future of Interventional Cardiovascular Medicine talks and presentation. And then it will be followed by 3 tracks. Coronary track, or call it this time, is virtual hall A for coronary intervention, and hall B for structural intervention, and hall C for endovascular intervention. In addition, we will have an abstract session, and also we have a very interesting virtual exhibition. Please visit that exhibition. It's very interesting, actually. And you have also some presentation inside the exhibition related to their products. I really would like to thank everyone from organizing committee, for scientific committee, for all the speakers. And of course, I would like to thank all of you who are joining us today and for the coming 2 more days for this educational feast. I hope all of us will have a great time and a good educational experience. And looking forward to see you next year in Dubai. Enjoy this wonderful meeting and have a good time. Thank you.
Thank you, Omar. Also joining us here is Dr. Jawara Al-Alal, as you can see here. She's also the moderator of this session. And Omar, if you would like to introduce her.
She is, yeah, I'm very pleased to have Dr. Jawara Al-Ali with us tonight in this meeting. She is the new president for Emirate Cardiac Society. She is a very active cardiologist in education. Rarely can find a very good educational program without her there. She have a lot of really activity in education, and we are very pleased to have her with us tonight. And if Dr. Jawara can present the speakers and kind of welcome aboard.
Thank you, Dr. Amr and Dr. Krager. It's my pleasure to be with you here, and 40S has been always an excellent program, and it's never missed. It's one of the best programs going on in the Middle East. So I think next we have the welcome message from the President of International Society of Endovascular Specialists, Dr. Orania Pervensa, and I'll leave you with her message.
Hello, I'm Dr. Orania Pervensa, President of the International Society of Endovascular Specialists and Multidisciplinary Society of Cardiac Surgeons, Vascular Surgeons, Cardiologists, and Interventional Radiologists, with the main focus to enhance global education and clinical expertise in the treatment of cardiac and vascular disease around the world. It is my distinct pleasure to welcome all of you to the 40S conference, Top-to-Toe Transcatheter Solutions. Dr. Omar Halak and Dr. Zvonimir Kraser have prepared an absolutely outstanding program with experts around the world to talk about structural heart valve disease, interventions, aortic endovascular interventions, new technology and devices to help clinicians deliver more precise and efficient care. how can we help somebody with peripheral vascular disease and heart disease, and what interventions can we be implemented to help reduce the burden of cardiovascular disease? Please join us and join Dr. Omar Halak and Zvonimir Krejzer in the next 2 days to learn more, to educate ourselves and help our patients. Thank you.
Very good. Thank you, Rania, for this introduction. As we can see, the ladies are taking over in the field of cardiovascular medicine.
They have been all along, but now they're showing up more.
Right. The next presentation is by our chairman, Omar Halak, who's going to give us the information on the latest advances in trials, clinical trials in cardiovascular medicine. Omar?
Hi, my name is Omar Halak. I'm an interventional cardiologist and head of cardiovascular department at King's College Hospital, Dubai. My talk is on latest clinical trials in cardiovascular medicine. First trial is Master DAPT. Question is 1 month of dual antiplatelet in high-risk patient will be as good as 3 months or more? 4,400 patients randomized to 1 month dual antiplatelet versus 3 months or more after drug-eluting stent placement. The outcome, primary endpoint was death of any cause, myocardial infarction, stroke, or major bleed. Result: at 1 month group, there was 7.5% adverse clinical outcome. In the 3 month group, at least was 7.7. So the conclusion from the trial, 1 month of dual antiplatelet was not inferior to 3 months or more, and patients will have less major bleed. Second trial is host exam. The question is clopidogrel can be used as maintenance for after stent placement after completing the dual antiplatelet course. 5,400 patients randomized to clopidogrel 75 milligrams or aspirin 100 milligrams after patients completed 6 to 18 months after stent placement. 24 months later, the patient on clopidogrel, they have primary outcome is 5.7. The one on aspirin was 7.7. The interpretation was clopidogrel monotherapy compared to aspirin monotherapy reduced the composite outcome of all death, non-fatal MI, stroke, readmission with acute coronary syndrome, and bleed. Scope, the question is to close or not to close the PFO. This is a meta-analysis of 6 randomized trial, total of 3,740 patients. They divided to medically treated versus closure of PFO in addition to medical therapy, and follow up for 57 months. The medical group have 1% event rate per year. The device group was 0.4% per year. There was significant variation on subgroup depending on the criteria of PFO or the criteria of the patient. Alternatively, is not really one answer fit it all. It really depends on the PFO. If the PFO is high risk, let's see, aneurysmal septum, or the patient have low risk of vascular disease, young man or young patient, no carotid stenosis, the benefit of closure PFO will be significant. However, if the patient have low risk of PFO, small PFO, and significant vascular risk, then the benefit of PFO closure will be limited. They have a scale of paradoxical embolism score and also Pascal score to grade those patients of the potential benefit. This is a mitral intervention, either with edge-to-edge repair or replacement of the valve. In this study, it includes 33,000 patients between 2014 and 2020. There was about 10 times increase the number of edge-to-edge closure, edge-to-edge repair of the mitral valve, the mitral clip, between 14 and 20, and also about 10 times also increase the number of mitral valve replacement. The mortality rate decreased from 5.6 to 4.6 in the edge-to-edge mitral clip, and improvement. There was significant improvement of the symptoms, at least one class improvement in 80% of the patients. The residual severe, moderate severe MR was only 8.7% in the clip group. In the replacement group, also the mortality rate dropped from 11 to 6, and also there was significant clinical improvement, and the residual moderate to severe MR was only 0.5%. So there has been significant improvement of the result of both mitral clip and valve transcatheter mitral valve replacement. Avatar is aortic valve replacement versus watchful waiting in asymptomatic severe aortic stenosis. 157 patients asymptomatic with severe stenosis, normal EF, negative stress test, randomized to surgical replacement of the valve versus watchful waiting, and followed on the endpoint was all-cause mortality, heart failure, or MI, or stroke. And this is the result. The surgical group have much less endpoint death, heart failure, MI. They have such increased risk of stroke compared to conservative group. So this is a curve for early surgical group versus conservative group. So it's obviously the early replacement of the aortic valve in asymptomatic severe aortic stenosis improve clinically relevant endpoint. Last trial, it's left atrial appendage occlusion during cardiac surgery to prevent a stroke. This is the question is the closure of the appendage during surgery will be beneficial in somebody who have high risk of stroke, have atrial fibrillation, a high risk stroke. 4,800 patients randomized to closure of the device, closure of the appendage versus just anticoagulation only in patients with atrial fibrillation and at least shared that score more than 2 or more. Also, the patients who underwent the closure of the appendage continue to be anticoagulated. The result, the patient underwent appendage closure after 3.8 years was 4.8, comparing to 7% of patients on anticoagulation only. So the conclusion of the trial that left atrial appendage closure kept 42% less likely of having stroke compared to anticoagulation again only. So it's comparing mechanical treatment and anticoagulation treatment is the best approach. Change the gear on FAME3. The question is a fractional FFR PCI was guided by FFR versus CABG will be have different outcome in patients with 3-vessel disease. 1,500 patients with a 3-vessel disease randomized to PCI guided FFR versus CABG. And at 1 year outcome, major adverse cardiac or cerebral event. The result was in patient with FFR guided group, it was 10.6% a primary endpoint compared to 6.9% in CABG group. And that's include death, myocardial infarction, or stroke. And conclusion from the trial was in patients with cerebral cell disease, FFR guided BCI was not found to be non-inferior to CABG at respect to composite endpoint at 1 year. Another FFR trial is to answer that question is non-corbett artery treatment by FFR guided versus angiogram guided will have difference outcome. 1,171 patients presented with STEMI underwent stent placement to corbett artery and then randomized to FFR guided versus angiogram guided stenting of the other arteries. And the average stent for the FFR was guided was 1, and the average stent per angiogram was 1.5. At 12 months, 5.5 patients with FFR guided trial have reached endpoint with death or revascularization or non-fatal MI, comparing to 4.2 with angiogram group. The conclusion from the trial was after putting stent in the corbett artery of STEMI patient using FFR to see the second stent need to be placed on non-corbett artery did not improve the outcome and was more costly. Dream heart failure, to answer the question, is injection of stem cell will reduce the recurrence of decompensated heart failure events. 565 patients with ischemic and non-ischemic heart failure with reduced ejection fraction randomized to transendocardial injection of stem cell versus sham procedure. After 30 months, the result after 30 months, the patient who received the stem cell therapy did not reduce the occurrence of the primary endpoint, which reduction of recurrence decompensated heart failure. However, there was significant reduction of the incidence of non-fatal myocardial infarction and stroke by 65%, and the incidence of cardiac death by 57%. Conclusion of the trial, therapy with stem cell MBC reduced the heart attack, non-fatal stroke, and cardiac death in patients with heart failure and reduced ejection fraction with high level of inflammation, but did not benefit to reduce the effect of decompensated heart failure. The last trial is a Voyage PAD. Follow-up on that trial is to answer the question, is combination of low dose of rivaroxaban with aspirin will be better than aspirin alone. 6,500 patients with peripheral arterial disease undergone lower extremity revascularization randomized to rivaroxaban plus aspirin versus aspirin alone. And the primary efficacy outcome, cardiovascular death, acute limb ischemia, major amputation, myocardial infarction, or stroke. Those outcomes occur in 17.3% in combination therapy versus 19.9% on aspirin alone. The conclusion of the trial was that rivaroxaban plus aspirin was superior to aspirin alone in preventing major adverse limb or cardiovascular event. Thank you very much.
Stimulating for everybody. I'm sure there's a lot of questions. I have a lot of questions, but we'll go to the next speaker now, Dr. Mariam Motar, who's going to talk to us about genetic testing in heart disease.
Good afternoon, everyone.
We cannot hear you well, Dr. Mariam.
Good afternoon, everyone. How is the volume still?
Good afternoon. I mean, the sound is kind of. Can you speak louder a little bit? The voice is very low. Actually, cannot hear well.
The ladies, they shouldn't speak loudly. 1 minute. I try my best.
Okay, thanks.
How is it now?
I think it's a bit
Hello?
better.
How is it now still?
It is better. Yeah. By the way, Dr. Mariam Matar is the president of United Arab Emirates Genetic Society, and we are very happy and pleased to have her with us.
Thank
I
you
think
very
the
much.
boss. Yes.
Yeah, thank you very much, Dr. Halab. And again, good afternoon, everyone. It's a great honor for me to be in such prestigious and well-known conference. And thank you very much, Dr. Umar, for
Pleasure to
inviting
have
me.
you.
Thank you very much. And when we talk about cardiovascular, again, it is one of the main and leading cause of death globally. And for me today, Dr. Umar, I tried my best within 10 minutes to summarize things related to genetic and epigenetic. It was very difficult. Dr. Umar is much easier if you can talk in minutes instead of 10 minutes. But in conclusion, I'll share with all my colleagues and my seniors some essential facts and information related to cardiovascular and genetic disorders. And allow me to start with a very basic information and knowledge, which I'm sure majority of you are aware about it. When we, in the past 4 decades, we used to always relate cardiovascular to the disease to a very few list of cardiac disorders. But with a huge advance in genetics and in future medicine, we were able to identify the high risk group not only on the genetic level, we are able to go beyond that on epigenetic level, especially in multifactorial disorders. And one of the top of the list is hypertension. For example, arterial hypertension is a multifactorial disease with several mechanisms and metabolic system involved in its pathogenesis. And when we come to the genetic factor and environmental background, that all may lead to alteration in multiple level and background on protein and genetic expression. And with such advance in medicine, where more people are involved in these studies, especially when it's come to identical twins, we came to know the huge influence of the environmental factor on a specific mutation, which was very common in some of the diseases. But in the same time, if we are able to control the environmental factor, we can have a huge impact in the prognosis of the disorders, and especially in the most common genetic disorder in cardiovascular, which is hypertrophic cardiomyopathy, where one case in 500 will be diagnosed with such disorders, and 90 to 80% of cases are familiar related cardiomyopathies, and they are autosomal dominant. But as soon as we are able to diagnose the environmental factor, the whole prognosis of the disease will change. And if we will go back to some of the factors which I would like to share, and I'm sure majority of my colleague and senior are aware about it, right now we are not waiting for the patient to present in the clinic with the symptoms and sign. We retrospectively target the community through a diagnosed patient in the clinic. So very soon, the insurance system will sue the physician, especially the cardiovascular, who is not allowing or not sharing any information of preventive screening with a diagnosed patient within their client. So it will be obligatory for us to go 3 level retrospectively from his family tree to identify any related risk factor presented in different morphology. So if we talk about what is the approach, there is well-defined approach by the American Society of American Cardiovascular Society, a very lovely, clear to the point flow is there, and I can share it with the audience as well. So when we talk about these investigation and how we as a physician are responsible not only to treat and manage the current cases within the clinic, it goes beyond that on three main levels: on genetic level, and epigenetics, and pharmacogenomics. And what makes us more confident and happy to provide this service, that these markers are accessible, affordable, and so far are accredited. So if we are able to empower our physician cardiovascular, especially in the clinic, with all these basic knowledge about the available preventive screening, we can save the community, and at the same time, it will have a huge impact on the application on the disease progression as well as preventive strategy. And one of the points which I would like to conclude in this 10 minutes discussion, we go back to an identical twins study which was run for almost 32 years between New Zealand and UK. And they followed up all those identical twins who by accidentally had a cardiovascular disorder or without. And they tried to monitor one main factors additional to other factors, but they try to look back at sleep. So those patients who presented with any cardiovascular symptoms or sign within the clinic, and the physician was emphasizing on managing his sleep to improve the quality of the sleep, either by himself or to be referred to a sleep clinic, they were a huge dramatic impact on the prognosis and increase the quality of the life of this patient. So in conclusion, right now, we don't define ourselves with only genetic screening for some known mutation. We go beyond that with identifying the epigenetic markers, which is mainly related to environmental factor, and the top of the priorities is sleep. And now there is also a very lovely recommendation will come soon. We had it a discussion when we talk about some rare diseases, how sleep, quality of sleep, improving quality of sleep will have a direct impact on the prognosis of the clinical setting of the case, and in the same time switching off some of the nasty mutation which increase the risk of the patient to develop further complication on the level of kidney or any other microvascular complication level. Finally, I'll go to one of the most common disorder, non-communicable disorder within globally as well as in our community, diabetes. And when we talk about diabetes and cardiovascular marker on epigenetic level and pharmacogenomic level, we came to know the relationship between familiar hypercholesteremia and specific type of mutation which increase the risk of the patient to develop cardiovascular disorder additional to all the complication of diabetes, but in the same time their response to specific type of pharmaceutical drug without mentioning any one of them, where we use them in dyslipidemia and introducing high fiber diet. And that specific type of autosomal dominant, which increase the risk for familiar hypercholesteremia, respond much better within 6 weeks with high diet with high fiber, at least 4 to 6 grams twice a day. Within 6 weeks, their cholesterol level dropped dramatically. Some of them dropped to 80 milligrams, and that itself, we believe, will have a huge impact on pharmacogenomic. So physician, before prescribing any type of pharmaceutical drug which will help to reduce the cholesterol, they will go first to find out the genotype and specific type of mutation. If they do have that, we will not overload their liver and their kidney with any pharmaceutical companies. Thank you very much, Dr. Umar Al-Hallab, and I'm ready for any discussion later on.
It was a great presentation, Dr. Mariam. Thank you so much. Hopefully we'll have enough time for discussion toward the end of the session.
Thank you very much. The next presentation is by an associate of mine and interventional cardiologist at Texas Heart Institute in Houston, Texas, Dr. Alex Postelian, and his topic is update on valve-in-valve TAVR.
Hi, my name is Alexander Postalian. I'm an interventional cardiologist here at the Texas Heart Institute. And I'm going to talk a little bit about valve-in-valve TAVR, what's the status in 2022, also discuss our own numbers a little bit. But first, I want to thank the organizers of the meeting for the invitation. It is always an honor and a privilege. And also, thanks to Dr. Krager for facilitating the interaction. What are the current clinical data for valve-in-valve TAVR? Because we started doing this procedure because we could, because it made sense. But what are the numbers now? There's been many studies published in the matter. This is a meta-analysis published in 2021. That's a good compilation. They include about 8,000 patients that underwent valve-in-valve TAVR versus 8,000 patients that underwent redo SAVR. But keep in mind that since the valve-in-valve patients were older, had more comorbidities, and had higher STS scores, they had to do propensity matching, which introduces bias, and we have to interpret this at your own risk, essentially. Mortality at 30 days, better for TAVR. They're at the top by a little bit. And mortality at 1 year equal for redo SAVR and valve-in-valve TAVR. Complications. Stroke, no difference. Major bleeding, there's a benefit for valve-in-valve TAVR. Length of stay, as expected, there is a significant benefit for valve-in-valve TAVR. And then interestingly, at the bottom left, pacemaker rates. It's a little complicated. Overall, there is no difference. However, you see that most recent study there, it's also one of the largest ones, published in 2020, shows a major benefit for SAVR as far as pacemaker rates are concerned. And there was an initial thinking that if you have a surgical bioprosthesis there, it might protect the conduction system from injury, but this may not necessarily be the case. There's a study published in 2021, 1,987 patients from the VIVID registry, and they had 4.7% pacemaker implantation rates with current generation valves, which is pretty good and standard. A major problem with valve-in-valve TAVR is patient prosthesis mismatch, and this showed a significant hemodynamic benefit for redo SAVR. However, this is something that can be largely be prevented, and we'll talk about that a little bit. In summary, lower 30-day mortality rates, less bleeding, shorter length of stay, unclear about the pacemaker rates, probably similar, and a worse hemodynamic profile for valve-in-valve TAVR. This is Dr. Michel Pompeu from Brazil. He's the one that led the meta-analysis, and it looks like for him, it's a win for TAVR, even though he's a cardiovascular surgeon. What do the guidelines say? Because we know there's a lag between evidence and guideline adjustment. 2021 ESC guidelines say that transcatheter valve-in-valve TAVR is an option for patients with increased surgical risk, as long as they're evaluated by a heart team approach. And the 2020 ACC guidelines are similar. They say that transcatheter valve-in-valve TAVR is an option for inoperable or high-risk surgical patients. And they comment that it is because redo SAVR has a lower mortality and superior hemodynamic outcomes. But if you see that number 18 there, which is the reference that they're talking about, that was a study, a meta-analysis published in 2017 that only had 342 patients. And the vast majority of those patients are included in the 2021 meta-analysis that I just mentioned, meaning that this is essentially out of date and trumped by the current data. So this recommendation is probably not current. How do we do the procedure here? There was a little bit of mystique around valve-in-valve TAVR at the beginning of the experience, but we try to keep it simple. And honestly, we try to just do it the normal way. We favor femoral access. We favor conscious sedation. We try to discharge the patients the next day and avoid ICU admission, as we do for all TAVRs. However, there are some things that are worth discussing. First of all, of course, we know that you have to be familiar with the surgical prosthesis that is implanted, particularly the fluoroscopic appearance, and if they are fracturable or not. These are, stented and stentless valves are the main classification. But I want to bring your attention to these two. The mitral flow on the top right. What's important here is that the leaflets are mounted outside the stent, meaning that if you put a valve inside it, you run a higher risk of occluding the coronaries with this valve. And then at the bottom, the Medtronic Freestyle is the stentless valve that we most commonly see. And what is important here is that you can't see anything on floor. It's very hard. So you have to do a lot of injections, and it's also slippery. So we have to be much more careful with deployment. Sizing is another big deal because the size labeling by the manufacturer is not the size that we're going to use to decide which transcatheter valve to use. We have to use the true internal diameter, which is usually available in the manufacturer documentation. However, there's an app for that we use all the time, this valve-in-valve aortic app. It includes most of the commercially available surgical bioprostheses. It clearly labels the internal diameter. It includes pictures of the valve, fluoroscopic images of the valve, and in a lot of cases, even a video of a deployment of a TAVR inside that valve to show you the exact ideal height. So we make a lot of use of this app. It's very helpful. Anything else that's worth considering? Predilation, probably not needed often. Snaring. Well, sometimes when you're advancing the transcatheter valve across the surgical bioprosthesis, it can become stuck, snagged in the annulus. So some operators advise to snare the valve, pull it in, and then advance it to overcome this. We find that wire position adjustment and a little bit of valve rotation is usually enough. We almost never do this. High implantation is favored for better hemodynamic results and for lower pacemaker rates. We do liberal pacing in these cases. Positioning can be a little bit more tricky than in regular TAVR. And for stentless valves like the Freestyle that I was mentioning, very, very slow deployment. Well, if it's a balloon expandable valve, we have to perform a lot of injections to make sure we're in the right place. And if it is a self-expanding valve, sometimes we stay 10 minutes or more at 80% deployment if it's a core valve to make sure that it expands and sits and gets opposed to the wall before we release it. And sometimes you can pace during release as well, which is not necessary for regular TAVR. There's two main issues with valve-in-valve TAVR that can probably be resolved. The first one is patient prosthesis mismatch. Can probably do much better if we select the patients appropriately, meaning if you have a patient that has a small surgical bioprosthesis or that they already have even a mild degree of patient prosthesis mismatch, that patient should go for SAVR if at all possible. We have to pick the right valve. We know that the self-expanding valves have better hemodynamic profiles, so we favor those. And bioprosthetic valve fracture is an option for some of the surgical bioprosthesis, but again, this option should be reserved for patients that cannot undergo redo SAVR. And coronary occlusion is the other feared complication that is not very common, but it can be catastrophic. It can usually be addressed by careful evaluation of the preoperative CT. On the right, you see a virtual heart valve. Make sure that the valve to coronary distance, represented there at the bottom right, is less than more than 4 millimeters or more than 3 in some newer series. Careful look at the calcium location. Make sure it's not right in front of the coronary because it can be pushed and occluded. And basilica is an option, which is intentional laceration of the bioprosthetic leaflets to open it up when you put the new valve in. It's definitely feasible and it works, but again, this should probably be reserved for patients that cannot have SAVR or surgical valve replacement. What do our own numbers look like? I think they look pretty good for the most part. We've done about 150 patients. Comorbidities were pretty standard. We had most patients were either severe AS or combined AS with aortic insufficiency, and a minority of isolated aortic insufficiency. This is in line with what's published out there, the distribution. Our mean STS score was close to 7%. We are at a perfect 50-50 distribution of self-expanding and balloon expandable valves. So we have brand equipoise. And procedural success was 100%. Hospital mortality 2%, which is high, probably skewed a little bit by our early experience. Pacemaker requirement 3.3%, which is pretty good. And we know that gradients post valve-in-valve TAVR are higher. We have an average of 17, which is also in line with currently available evidence. And our length of stay our mean was 3.7, which is higher than, I think it's also skewed by the early experience. because our median length of stay for regular TAVR is actually 1 day now, and for this it's closer to 2. What questions remain? Well, type and sequence of valves. Should we do SAVR, then TAVR, then TAVR, or TAVR, then SAVR, then TAVR? And if you're going to do TAVR, then self-expanding and then balloon, and then, or balloon and then self-expanding. There's arguments that can be made that make sense, but this question is incompletely answered. Same thing for fracturing the bioprosthesis before or after implanting the new valve. We favor doing it after, because that way you avoid torrential aortic insufficiency for a portion of the case, but you also run the risk of injuring the leaflets. Future coronary access is always a concern when you're adding more and more metal to the aortic root, but hopefully newer iterations of the transcatheter valves are going to continue to improve this. Role of embolic protection devices, they might be more important for valve-in-valve TAVR than regular TAVR, because there's a higher likelihood of embolizing debris. We don't know. Same goes for the role of anticoagulation. We have a low threshold to anticoagulate these patients, but again, more evidence is required and more long-term data are needed. What's the verdict then? I think that valve-in-valve TAVR is safe and feasible, and probably should be the procedure of choice for most patients. Right now, the guidelines recommend you cherry pick cases for valve-in-valve TAVR and do SAVR for the rest. I think it probably should be the other way around. Most patients who get valve-in-valve TAVR, they're usually older patients for the most part. They also have higher surgical risk. They already have a sternotomy and major surgery done. However, I think SAVR is definitely the better option if feasible for a small prosthesis, patients with small aortic sinuses and risk of coronary occlusion, and very young patients that are at very low surgical risk. Thank you very much for your attention. This is my name and my email. I would love to hear questions, comments, concerns, critiques. Please share them and I will respond. And enjoy the rest of the presentations. Thank you very much again.
Good morning. This is Dr. Leslie Miller. I'm very pleased to be included as one of the presenters in this very prestigious and very ideal conference dealing with a number of issues in today's cardiovascular medicine. This morning, I will discuss a common problem for those physicians involved in the use of intravenous contrast, whether in the catheterization as interventionalist or other diagnostic procedures. These are my disclosures. The incidence of IV contrast-induced acute kidney injury varies considerably and is based on the baseline renal function at the time of the contrast exposure, the total contrast load, the osmolality, the lower the osmolality, the seemingly less injury induced, the status of the pre-study hydration in the patient, and the post-study hydration to try and recover from the potential insult of IV contrast. Several agents have been used over time, including IV bicarb and renal dose dopamine, but none of these have seemingly provided significant advantage over just IV hydration with intravenous fluids. The highest risk patient population that are increasingly common in the interventional catheterization laboratory are those patients with acute heart failure and some type of either acute or chronic kidney disease. In these patients, any nephrotoxin has potentially significant consequences. For example, if a patient requires multiple PCI procedures during one diagnostic or interventional cath or other contrast loads, we know that those patients with the most advanced acute or chronic injury, the presence of contrast nephropathy includes increased morbidity, increased length of stay, obviously cost of care. And these patients often are managed with multiple stage procedures instead of one large contrast exposure at one time, which ties up further patient flow. This population with diuretic resistance, or what we refer to as cardiorenal syndrome, whose renal function has worsened from the time of admission despite IV diuretics, are actually linked to an increase in mortality that extends beyond the initial hospitalization for the following year. And so this population is particular of interest. I want to propose a new approach to renal protection in the cath lab, and that is the use of mechanical circulatory support devices. These devices can provide significant and excellent renal protection by providing as much as 2.5 liters of additional augmented flow over native cardiac output and pressure, with some devices documenting an increase in renal blood flow by up to 50%. This has very salutary effects on improving the intrarenal filtration gradient, and these devices are remarkably easy to insert and remove in the cath lab. The first such device that might be considered is the intra-aortic balloon pump. It's been available for over 40 years, but there's very limited data on actually providing protection to the kidney during its use. Its major benefit is improving coronary blood flow, with modest impact on those with non-ischemic heart failure in terms of changing cardiac output or venous congestion, and almost no data on actual renal protection with its use. These are three of the newest devices in the field. They are percutaneous temporary mechanical cyst devices, all of which are placed in the descending aorta and in proximity to the kidney. The first device is the CardioBridge device, which has been reported in a clinical trial 2 years ago of 16 patients with very severe advanced biventricular heart failure, 50% of whom had not only failed diuretics, but had been on IV inotropic therapy. As you can see from the baseline, as a very modest urine output despite the continued ongoing IV diuretic therapy. With the initiation of the device, it reached a peak of 250 milliliters of urine output at 12 hours and averaged 150 at the end of that. So a 4 to 5 liter urine output. And importantly, as you can see below, the serum creatinine actually improved despite this significant diuresis. This was the first in a series of reports that documented the benefit. The second device is an interesting microaxial flow pump that's also placed in the descending aorta, the so-called Procerian aortic device. It's a fairly larger device. It's an 18 French and requires up to 25 to 30,000 RPMs, but in the acute setting has actually been shown to be effective. This does not augment flow directly as the impeller pumps do, but in fact entrains blood through this microaxial pump. There's been a report of its use in support of high-risk PCI procedures in a first-in-man proof of concept trial in Asunción, Paraguay. And I think you can see in these patients who were relatively oliguric despite IV therapy prior to the procedure, had a very significant improvement in urine output over the duration of the procedure, and also was associated with no change in serum creatinine. This is the third device, which is the second heart assist device. It's a 13-point French device that takes less than 2 minutes to fully deploy. It is an impeller-driven pump placed in the descending aorta. And as you can see, with the use of a control knob handle, it allows the stent to open and the impeller blades to open. At the end of the case, the impeller blades are collapsed and the sheath returned, and then the unit removed entirely as one unit. This is placed through the femoral artery, and as you can see, the inferior portion of the stent is placed at only 10 centimeters above the renal artery, and this is the catheter for which the 50% improvement in renal blood flow has been documented. It's a very simple machine placed next to the cath lab table that has a motor outside the body. It uses a simple irrigation system to keep the device lubricated, and has a control knob, as you can see, which can adjust the speed of the device. This is an actual, grainy picture, but during a PCI procedure with this catheter, also done in Asunción, Paraguay, you can see there's ample clearance between the blade tips and the struts of the stent. And this is a magnified view of its look during a procedure. This is similar to the report from the Procerian device of the 4 patients who had 3 IV contrast loads in 24 hours. They had a diagnostic coronary angiogram to define that they, in fact, did have high-risk anatomy for this PCI procedure, including at least 2 lesions that warranted intervention and were high risk by either very limited additional flow or major vessels such as the left main or proximal LAD. So that large diagnostic load was followed by the next day to confirm aortic diameter, a second interarterial injection to look at aortic diameter. And then that was immediately followed by a third contrast load in 24 hours to actually perform the 2 to 3 vessel PCI procedure. Now, these patients all presented the cath lab with prerenal azotemia and oliguria. And as you can see, they made only 25 cc's on average prior to the cath procedure. And all 4 of them had a nearly 4-fold increase in urine output, despite a third IV contrast load in these patients. And very importantly, the creatinine was unchanged at the time of discharge the following day, which really documents the significant renal protection that these devices can provide. So I think I've tried to give you some ample evidence that this new approach using these temporary mechanical circulatory assist devices, which are placed percutaneously, can provide excellent renal protection. They're very quick and easy to insert and remove in the cath lab, and they may increase renal blood flow by as much as 50%. This reduces the likelihood of developing contrast-induced kidney injury with all of its associated morbidity and complications. It's ideal for patients with acute kidney injury from acute decompensated heart failure or those with pre-existing chronic kidney disease in addition. And it's applicable, importantly, for use in all patients with some degree of chronic kidney disease undergoing IV contrast use, and will expand the role of the cath lab and interventionalists in avoiding this particular adverse effect. Thank you for your time.
Thank you, Dr. Miller. It was a really very interesting presentation and definitely well needed in the cath lab. And the next speaker will be Dr. Jack Jacob, and his talk will be angiogenesis as a revascularization strategy on severe coronary artery disease who have no option of revascularization.
Okay, I'll begin now. I'd like to thank Dr. Halleck and the organizers of the 4TS conference for inviting me to give this talk. I'll be talking about using therapeutic angiogenesis. Angiogenesis is the growth of new blood vessels, and talk about revascularization strategies for patients suffering from severe coronary heart disease. I'd like to thank Dr. Halleck. I borrowed this slide from him. So the big question is, can we induce the growing of new blood vessels, excuse me, in ischemic areas? And I hope to convince you at the end of this talk that yes, indeed, we can grow new blood vessels in patients with severe coronary artery disease. Now, the process of angiogenesis, or new blood vessel growth, is a natural process. We use it all the time. This shows it in a wounded area. If we look underneath, let's say, the scab area, we can see this wounded area, and it's being perfused by brand new blood vessels. This is the process of angiogenesis. This is stimulated by the drug that we're developing, and I'll talk about that drug in a second. But this brings blood perfusion into this wounded area and heals, in this case, skin as an organ. But the same thing can occur in the ischemic heart, where we can get better vascularization to relieve the ischemia in those patients' heart. This is the drug we're developing, FGF1. It stands for fibroblast growth factor 1. It's a protein like insulin or growth hormone. It's not a gene therapy or messenger RNA. It's a natural product in the body that can potently stimulate the growth of new blood vessels, which is called angiogenesis, and also the growth of small arteries, which is called arteriogenesis. It just shows you we manufacture the protein with industry standard technology. This is our manufacturing plant in Spain. So the FGF1 we make is pure, potent, and ready for use in humans. This slide just reviews how FGF1 initiates this process of new blood vessel growth, or angiogenesis. So in a natural state, if we say wound ourselves, cut ourselves, our body makes the FGF1 protein. It binds to FGF1 receptors, as shown here, and this stimulates the process of new blood vessel growth. So the endothelial cells start dividing, enzymes are released which degrade the wall of the artery, and here we see a new tube, a new blood vessel being formed, and the vessels grow directionally into the area of ischemia. So that's very important. There's a directional growth of the new blood vessels, and also when in ischemic tissue, the number of the receptors, FGF1 receptors, get upregulated. And this can be as high as 10 to 100-fold, which gives us a very nice safety window. So if you inject this growth factor into normal heart tissue, you get no angiogenesis, no blood vessel formation. Only if the heart muscle is ischemic do you stimulate angiogenesis. So let me talk about two vascularization strategies we're using in humans with FGF1. We're doing clinical trials where we give the FGF1 along with a bypass CABG procedure. So a lot of CABG procedures are areas of the heart that are ischemic that can't be revascularized. So we can inject the FGF1 directly into those distal areas. I'll then talk about human clinical trials where we're giving the FGF1 as sole therapy to induce angiogenesis. Okay, so in the first clinical trial, this was adjunct therapy with CABG. So this was in patients whose heart had been stopped on a heart-lung machine, get the bypass, and then for about 10 minutes, the surgeon would inject the FGF1 into 4 to 6 areas, which he feel would not be revascularized. And you can see after about 3 months, you get a nice blushwork of brand new vessels in this ischemic area. And these vessels are durable. They can last, we look 3 years out. So in these patients, here's after 3 months. This is looking at microvascular density, where we injected the FGF1. After 3 months, we see a nice increase in vascular density. And after 3 years in that same area, those vessels are still there, they're patent, and they're doing their job. Now, the second revascularization strategy is using only our growth factor, only FGF1. And we've done 3 independent clinical studies. We've administered the drug surgically through a mini thoracotomy, and then also with 2 catheters, cardiac injection catheters. And I'll talk about that in a second. So the first clinical trial in 20 patients was through a mini thoracotomy surgically. We injected the FGF1 directly into the heart of what we call no option patients. So they couldn't have CABG or stents put in. And we can see a nice increase. This is 90 days after we injected the growth factor. This is SPEC at rest. 90 days, see a nice increase in perfusion in the areas which were injected. Here's stress SPEC. And we can see here 16 out of the 20 patients improved that we treated, for a very significant increase in perfusion in their hearts. We also looked at exercise performance on the bicycle. And again, 18 out of the 20 patients had an improvement in their exercise performance after 3 months or 90 days. Again, highly significant. Now, in the second sole therapy trial, this was done in the United States. We had 6 clinical trial sites. And I just want to show you, this is a 1-minute news clip that ABC News, our national news service, went down to one of our clinical trial sites at the University of Cincinnati and interviewed our cardiologist. And I'll show you this because there's a nice picture of the angiogram of the patient who was treated. And you can see the new capillaries, blushwork of new capillaries formed.
But since receiving an experimental treatment for his blocked arteries, his pain is gone.
And I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
We see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
Okay. We then went on in our next two trials. Instead of doing surgery, we did a less invasive using a steerable cardiac injection catheter to introduce the FGF1. So up through the femoral artery, over the aortic arch, and injecting now inside the heart in the left ventricle, which had been pre-mapped to see where ischemic regions were. And this, in this trial, we used a Johnson & Johnson injection catheter called the MyoStar injection catheter. It's a steerable catheter. It was used in conjunction with their NOGA electromagnetic mapping system. Unfortunately, this system is no longer available, and I'll talk about the new catheter we're using. But in this study, we use this catheter to navigate into the heart, inject the FGF1 into ischemic regions, and the interventional cardiologist would tend to make between 6 and 10 injections inside the heart. The procedure would take 30 to 45 minutes. Again, these were no option heart patients, could not have cabbage or stents put in, and we saw a dramatic improvement in their angina scores. Entering the pre-treatment, entering the trial, they all were had severe angina, class 4 or class 3. 12 weeks after we treated them with this catheter injection technology, we see a very nice improvement in the angina scores going to class 2 and class 1. We put them on a treadmill for exercise performance. Here's pre-treatment, and again, post-treatment, this was statistically significant improvement in their exercise performance. So, as I mentioned, this MyoStar catheter is no longer available, so we found a new catheter made in Germany, in Bavaria, and this is actually an interesting steerable catheter. Here's the tip. When the needles are deployed, 3 separate needles get deployed, and this actually gets more drug into the ischemic areas. And again, we can do 6 to 10 injections throughout the heart. So this is the catheter we're now using in our upcoming clinical trial, which will be done in 3 different countries. And we're looking for patients. You can go to our website, zgm.care, to sign up, or if you have patients, no option heart patients that would like to explore treatment, please go to our website. So I thank you for your attention. I'd be happy to take any questions.
Interesting presentation, and we'll have some discussion toward the end. I think we have the last talk today from Dr. Jihad Mustafa. He's going to LI. Dr. Jihad is the president of the Society for Global Leg Ischemia.
Hello, this is Dr. Mustafa from Grand Rapids, Michigan, in the United States. So now to be speaking on the 8th annual 4TS meeting. Today I'll be talking about the global approach to CLI. These are my disclosures. What I could do take 10 minutes to show you slides and data on CLI, amputations, and death rates in countries around the world. And I could run over my time limits talking about how we don't have globally accepted guidelines for the treatment of CLI, and we could come to this conclusion. None of us are doing a good enough job. So therefore, we are essentially on the same page. Instead, what I'm going to do, discuss what we need to do to all get on the right track. We will have to discuss common themes among all CLI patients, discuss mortality and morbidity associated with different types of CTO lesions, discuss what treatments we need to urgently and globally address for this CLI pandemic. In the PRIME registry for endovascular clinical outcomes, the multiple centers observational registry for 3-year follow-up, we looked at included patients with PAD, Bradford class 3 to 6, undergoing peripheral vascular intervention. First patient was enrolled in 2013, up to 1,000 patients enrolled at 5 centers. What we looked at the time is, at the end of this time period, is the CTO and its association between its presence, its characteristics, and midterm outcomes in patients with critical limb ischemia. And this manuscript was published in the CLI Global Society Journal. So why study CTOs in PAD and CLI patients? We started to notice that the location of the CTO is associated with poor outcomes, some worse than others. So CTOs represents a substantial percentage and challenging subgroup in peripheral arterial lesions requiring endovascular interventions. Distinct from coronary disease, the dense collagenous lesions, they're often long and characterized by organized occlusive thrombi that results from a cyclic silent episodic rupture with subsequent healing that happens over and over again. So CTOs are primarily located in the femoral popliteal segments in patients who suffer from claudications. And while 2/3 of CLI patients have multiple disease distribution, the location and extent of arterial occlusion directly impacts the crossing techniques and treatment modalities required for successful interventions. PAD CLI CTOs are complex and multi-layered. Our investigation has shown the relationship between heterogeneous CTO characteristics and the patient's baseline presentations are associated with morbidity and then mortality as well. So that was a big eye-opener to see. So hence, it is essential to continue to advance medical knowledge and enhance treatment strategies for this complex patient population. For the sake of discussion, this was the PRIME registry, so therefore we named the CTO lesions as PRIME 1 through 6, where PRIME 6 extends from the superficial femoral artery and reconstitutes in the pedal circulation. And as you can imagine, that PRIME 6 is probably the worst type of CTO that you want to deal with. And going backward, PRIME 5 starts in the tibial arteries and reconstitutes in the pedal arteries. Also, that's a bad CTO to deal with. And PRIME 4 starts and reconstitutes in the tibial arteries. And PRIME 3 starts in the SFA or popliteal and reconstitutes in the tibials, meaning that every time I mention this, the junction between the popliteal and tibials is missing. And the junction between the tibial and pedal arteries or any other CTOs and the pedal arteries is missing. Every time a junction is missing, that represents a significant serious consequences and a challenge for the patient and also for the operator to reconstruct these disease segments. So if we focus on prime 6, 5, 4, and partially 3, we can see that the lesion characteristics had associated increase in lipidemia, diabetes, coronary disease, and CKD. So CKD plays a major role in the Rutherford class, as well as the CTO location, mainly like Rutherford 6 patients, and also prime type 6 and 5. And in this 450 CTOs that were treated, 411 patients, CTOs had 86% of them had severe calcification with median CTO length of 20 centimeter. I mean, this is really a complex cohort of patients. The locations of the CTOs were at 3 levels. Most common locations were majority of the primes were was by type 2, as you expect, and followed by type 4. But prime 5 and 6 were 2% least common, but the most cumbersome. Patients and lesion characteristics by CTO locations. History of smoking was associated more with claudication or claudicant-like disease, and therefore the CTO is located above the knee. As you would suspect, diabetic patients had an associated lesions that shifted more toward below the knee and or multi-level disease. Patients with GFR of less than 30 up to less than 60 were associated with disease CTO location that is below the knee, that includes also below the ankle as well. And then Rutherford 4 to 6 patients had more below the knee disease and multi-level disease. And it's very important to remember that Rutherford 4 to 6 have more below the knee disease and multi-level disease. The clinical outcome by CTO location, this is really important for you to remember and then use it in your daily practice. Revascularization results in improved mortality and amputation-free survival with acceptable TLR rates if you addressed the CTO based on its location. So when you're looking at prime 4 and 5, you notice that the outcome was statistically superior to when compared to 3 and 6 and compared to 1 and 2. But in prime 1 and 2, the freedom from 1 year mortality was 97. In 3 and 6, 86, and BTK prime 4 and 5 was 83, and all of them were statistically significant from each other. But if you look at the measure amputation-free survival throughout 1 year, you notice if you compare prime 1 and 2 to prime 3 and 6, and then prime 4 and 5, so basically what we mentioned earlier, 6 to 3, statistical significance was much higher. Therefore, those patients have to be addressed and treated very, very well and early. Association of baseline characteristics with clinical outcomes 1 year. As you would expect, the patients with CKD or hemodialysis or diabetes or the combination of the two had the worst outcome at 1 year. That includes major amputation and mortality as well. And the prime CTO 6, 5, 4, and 3 had also similar outcome at 1 year, poor outcome associated with mortality and major amputation. So therefore, please address those patients as early as possible. Multi-level and BTK disease carry high risk for major amputation and death, and you can imagine why, because you have more diabetes and CKD disease, and also because it involves the tibial junction, and as well as the pedal circulation as well. Hence, the high rate of major amputation in BTK disease is associated with high rate of death. So a study conclusion here, the lowest percentage CTO characteristic location was the level of tibial junction, prime 5, but also was associated with the highest rate of mortality and major amputation. Surprisingly, patients with prime 5 CTO were found to have the highest level of mortality and major amputation in all subset of patients. It's Dr. Mustafa, and thank you for the opportunity.
Thank you so much, Dr. Mustafa, for this excellent presentation. Now the floor open for questions. Do we have any question from the audience?
So I think until we get any question from the audience, maybe I'll start you off, Dr. Umar, with a question. You
Yes.
presented so many interesting trials, and of particular importance is the Avatar trial with asymptomatic severe AS patients. So there were only 150 patients in this trial. Do you think this will change the way we manage patients right now, or do we need to wait a little bit for more?
This is a pilot study. I think it's a small study, but it given a kind of signal that maybe early intervention for asymptomatic severe aortic stenosis may have a clinical outcome. I think it's too early to start recommended, but at least we have now some data we can build on it, and probably down the line it's going to be TAVI for asymptomatic severe aortic stenosis. Probably there might be some study going on now to show that maybe asymptomatic severe aortic stenosis may benefit from TAVI compared to just continued conservative treatment.
What do you think, Dr. Alexander? I'm sure you will do a lot of interventions with TAVI. How do you think evaluation of asymptomatic severe AS is going to be in this time and age? Is it enough to do an exercise test? Do you need biomarkers to be sure that they're asymptomatic? What do you think?
Yeah, well, I think if somebody has abnormal cardiac biomarkers, that's definitely something that would tilt you towards thinking maybe early intervention would be better. And, how common is it, like truly asymptomatic severe AS, if you exercise a patient and if you really just have the symptoms? I mean, it's I think it exists for sure. And my belief on the available data that we have is that it is probably beneficial to address that rather than leaving it alone, of course, depending on the clinical situation. So I think that might be the case in the future.
Thank you.
I have another question with the availability of the option of TAV valve in valve. Do you think we need to kind of discourage putting any mechanical aortic valve or even mitral valve for that matter? Just avoid any, because if you have mechanical valve, I mean, not much you can do except something goes wrong with it, you just take it out and put another open heart surgery. But do you think we should discourage any mechanical valve to be put in the heart?
Yeah, that's a very interesting question. If you look at the trends, for sure, there's a higher proportion of bioprosthesis now compared with mechanical valves than before. And that trend is probably going to continue as the technology and the long-term data with bioprosthesis improves. And of course, if you have a really young patient, then that's a different question. But maybe a patient that's in their 50s or 60s that before might have had a mechanical valve, now you have to consider the whole picture and think about what's going to happen when the patient is 80, 85, 90. So I do think there is a lower threshold now and going forward to do a bioprosthesis rather than a mechanical. Yeah.
What do you think, Dr. Krager, for young patients who have severe aortic stenosis, probably bicuspid? Should we consider just bioprosthesis, or if you don't want to put TAVI, should you put the bioprosthesis or as a standard recommendation to mechanical?
Well, in younger patients, as Alex has mentioned, it's an issue that of durability with the current generation of valves. So the current guidelines and criteria are patients that are younger than 65 should be treated with surgery and probably get a mechanical valve unless there are some either relative or absolute contraindications. As Alex mentioned, those guidelines might change. I think that the durability of bioprosthesis will change over a period of time. There are some methods of improvement as far as durability is concerned. And I think the guidelines will change in the future, but at the present time, in younger individuals, still surgery is a better option if there are no other contraindications.
Yeah, the issue is really for lifelong anticoagulation is really about a lot of headache for a young person, 30 years old, to take the anticoagulation on warfarin. Actually, they cannot take even NOAC. They have to warfarin is so complicated. I mean, really the life of patient taking warfarin is kind of really very difficult.
Yeah, now
doing TAVI every 10, 15 years, I think it's probably a good option for them, better than taking the anticoagulation lifelong. But of course, we have to wait for the guidelines. But I think in the future will be really, if we are able to avoid anticoagulation, warfarin in particular, I think will be a really good option.
Dear Chairman, I have a question, if it is possible.
Go ahead, please, Doctor.
Yes. Again, going back to regenerative medicine and epigenetics, as my question to all of my seniors who are on the panel with me, what about the role of microbiome? Right now, we understand and we came to have a better understanding about the relation of leaky duct with a specific common clinical presentation with palpitation, ischemic heart disease, and as soon as you improve the balance of the microbiome, you can see a dramatic improvement in the clinical presentation of the patient. I don't know, is there any role in the clinical trials, which I heard in the past 5 presentations? Do you do a regular investigation for the microbiome culture or the balance?
Dr. Juwari may answer that question. That's very tough for me.
Okay, because you're an interventionist. So this is not part of our regular, clinical evaluation. This is, if there is a lot of literature about it, then this has to land in clinical trial situations, but not as a regular day-to-day clinical practice.
Yeah, is there any chance to be thought within all those clinical trials which are going on as a parallel procedure? And I think that will be an eye-opener, and it will help us a lot in improve the quality of life by a very simple intervention away from pharmaceutical or intensive intervention, in my opinion, from a regenerative medicine point of view.
It's an
Absolutely,
interesting
this is definitely very interesting thought, and probably need to be looked at it more seriously. And as you mentioned in your talk, that probably avoiding a statin by doing something else, that can be great if you are able to find a way to lower the amount of medication we give patient for high blood pressure or heart failure or dyslipidemia or all those cardiovascular disease by doing something in their by abnormal biology in their body. I guess this is a great idea to study it a bit further, for sure.
That's true.
Okay, so like we came to the end of the first session. I really want to thank all of you for being in this session. I would like to thank for all the audience, and we will welcome all of you now to go to those 3 virtual holds, 1 for coronary, 1 for structural, and 1 for endovascular. Thank you.
Thank you so much.
Thank you.
Bye. Hi, Annie. Can't hear you.
There. Sorry about that.
Hi.
How are you? The conference is so amazing. I love it.
Thank you.
I had questions for the angiogenesis doctor.
Yeah, we're going to start actually for, unfortunately, because of the time limit, we already going to go for the next session.
Right. No
Yeah.
worries. That's
So
okay, later.
Yeah. So the whole A, I guess the one we are in now, is going to be for coronary intervention.
Yes.
And we have now the new moderators. And also Annie, you are one of those new moderators in there.
Yes.
To to start the session. And if you want to go ahead and welcome everybody and then start the session in coronary intervention.
Wonderful. Welcome everyone to our Hall A challenging cases, I believe. And it looks like here we have several of our moderators. We can't see them and we can't hear them, but I would like for them to be on.
We have Dr. Naji Yazbek. We have Dr. Zaman, Asfar Zaman from UK. And we have Dr. Muhammad Egred from UK. We have Dr. Fikri Deep from UAE.
Dr. Fikri.
And Dr. Naji Yazbek from Dubai. And of course, we have Dr. Annie, the famous Annie from Houston, Texas.
From Houston, Texas. It's so great to see you all. I had to get up really early for you all. I love it. What an honor.
Thank you for being with us. Thank you so much. And I guess we're going to open up the session for the challenging cases.
Wonderful.
Go ahead, Dr. Annie.
I think I will go ahead and introduce Dr. Ahmed Halak from the USA, my good friend and son of Dr. Halak. And he has some great cases about coronary aneurysm coiling. Go ahead, Dr. Halak.
Hello, everyone. My name is Ahmad Halak. I'm a vascular medicine fellow at Ochsner in New Orleans, Louisiana, and I'm presenting a case of successful embolization of a large LAD aneurysm using multiple hydrocoils. So our patient is a 72-year-old male who presented for evaluation for renal transplant. He has end-stage renal disease on dialysis, controlled diabetes, hypertension, and hyperlipidemia. During his preoperative evaluation, he underwent a PET stress test, which revealed perfusion abnormalities in the territories of the LAD and the RCA. So this was followed by a coronary angiogram, which revealed a mid-RCA chronic total occlusion, a mid-LAD subtotal occlusion with an associated large LAD aneurysm, as you can see in the video. So the intervention planned was endovascular, and the mid-LAD was ballooned and stented with 3.5 by 26 millimeter stent. And afterwards, angiography showed that there was a significant decrease in the filling of the aneurysm, but as you can see, there remained a small residual neck that was filling into the aneurysm. So using a microcatheter, the hydrocoil embolization system, which is used for intracranial aneurysm coiling, was advanced through the struts of the stent and into the aneurysm. And coil after coil was deployed until repeat angio showed near opacification of the aneurysm. So we'll go through these. As you can see here, there's almost no more filling into the aneurysm. So at this point, a subsequent 4 by 12 millimeter stent was placed in an overlapping fashion to completely occlude the remaining flow into the aneurysm. with 0% residual stenosis post-intervention and no procedural complications. So coronary artery aneurysms, and I'll talk about aneurysms in general, they describe a localized dilatation of an arterial segment at least 1.5-fold the normal size of adjacent normal segments. The incidence ranges anywhere between 0.3 and 5%, but contemporary studies have shown that the incidence of true coronary artery aneurysms to be less than 1%. There's a strong link with coronary artery disease, and several aneurysms will appear at the site of stenosis, likely due to increased pressure on pathologic arterial segments. Drug-eluting stents are also notorious for causing aneurysms, and this is due to the drug that's being eluted to delay re-endothelialization and cause inflammatory changes of the medial wall and cause hypersensitivity reactions in some patients. Other causes of aneurysms include vasculitis, connective tissue disease, infections, drugs, and genetic factors. And there's currently no consensus on the optimal management of coronary artery aneurysms. The treatment options, aneurysms can be treated medically, which focuses on risk factor modification, controlling blood pressure, cholesterol, and diabetes, etc., plus or minus anticoagulation to prevent intraaneurysmal clot formation. Endovascular treatments offer the benefits of reduced invasiveness, decreased length of stay, less wound complications, a faster return to normal activity, and quality of life in the short term. Surgical treatments offer the benefits of durability, reduced need for follow-up, and low mortality in elective cases. Surgery may be preferred in emergency situations, such as aneurysmal rupture, but some factors may favor endovascular approach, such as a hostile abdomen, high-risk surgical candidate, and the aneurysm not being easily accessible, especially in morbidly obese patients with several previous surgeries. So if you do plan on doing an endovascular approach, you need to evaluate your collaterals. If you have good collateral flow, you can consider embolization with coil or glue. And if there's bad or absent collaterals, then you would have to consider a stent graft or a multi-layer flow modulating bare stent. Basically what this is, it has a 3D geometry which slows the velocity of blood leaving the aneurysm, leaving the stent. And this allows organized thrombus to form, and it preserves the blood flow to visceral arteries. This was published in the Journal of Vascular Surgery. As we can see here, this patient had a salmonella-induced rapidly expanding aortic pseudoaneurysm involving the visceral arteries. And as we can see here, the stent was placed, and there's still contrast reaching into the renal arteries. So this reduction in the velocity reduces the pressure, and it makes the aneurysm less likely to expand or rupture. It hasn't had widespread recognition or favorable outcomes, but a recent meta-analysis and systematic review published in the Journal of Vascular Surgery basically had over 400 patients, and it's kind of indicated that the multi-layer flow modulating stents are safe and effective in treating challenging aortic pathologies, complex aortic lesions. Other things you need to consider is the adequate sealing zone. For the aorta, I used the reference neck length less than 15 millimeters, diameter more than 28 millimeters, angulation more than 60 degrees, and calcification more than 50% of the circumference. All of these are, increase the risk of the adequate sealing zone being inadequate. Another thing you need to assess for is the potential for kinking. And the potential for kinking, several independent predictors are available, including female gender, the neck angulation, the experience of the team, the duration of how long the stent is implanted, the ASA classification, and the type of device used. As we can see here, this is a patient who's 67 years old. This was published in the Vascular Specialist International Journal. He had his AAA repaired in 2005. The image on the left is from 2010, and he was lost to follow-up. And in 2014, he complained of severe left leg pain. As we can see, there's kinking here in the left limb of the stent. And the final thing to assess for is the accessibility of proximal vessels. This chart published in the 2021 Journal of Clinical Medicine, it shows the type of aneurysms and the options for endovascular treatment of each, depending on if there's visceral arteries or other factors. Complications of endovascular intervention for aneurysms: distal thromboembolization, non-target vessel embolization, coil migration, end organ infarct, and intraprocedural aneurysmal rupture, although the procedures are generally well tolerated and safe. And in conclusion, this case demonstrates the ability to embolize a coronary artery aneurysm using coils with overlapping stents when other options are limited. The patient did well post-operatively with no complications. Thank you very much for your time and attention. If you have any questions or comments, please share. Thank you.
I am Professor Mohanad Egred, Consultant Interventional Cardiologist at the Freeman Hospital in the United Kingdom, Newcastle upon Tyne. My task today is to talk to you about managing uncrossable lesions. I thank Dr. Halak and the organizing committee for this opportunity. And this is going to be a whistle tour through a really complex and demanding subject, but we'll try to do it within the allocated time. These are my conflict of interest. As we know that uncrossable lesion can be faced with every day. And I'm not going to talk to you about CTOs today. I'm going to talk about the failure to cross either by wire, balloon, or a stent. And you know that we are treating really elderly population right now. As you can see, this is from the PCES database in the UK. There's a large chunk of patients more than 80 years old that you expect to have some difficult uncrossable lesions. And if you have that in mind, you know that what you're going to be faced with. And 65% of our cases currently are acute coronary syndrome when you don't know what the anatomy might be. And of course, when is it likely to be faced with a fibrotic calcified lesion or difficult lesion? Usually in the elderly, as you mentioned, somebody with renal disease, if there's a visible calcification when you are taking the pictures, and also in tortuosity and aortoosseal disease. There is to be a test or trying to pass an IVUS catheter, and if it doesn't pass, that usually called the Washington test, and that means you probably need some debulking and modification of the lesion. Now, of course, the best thing is to think about the basics. If you see this and you know you're going to be faced with trouble, there's nothing to stop and upgrade to 7 French or even 8 French if required. Use a long sheath to give you the best support. You go for a supportive guiding catheter as well as supportive wire. We know the support from the guide catheter could be passive or active. The passive support, if you go like an AL1 that is really big, or AL2 even. The active support, when you could engage the guiding catheter inside the artery, deep throating as it used to be called before. And of course, the first thing you try is to use a small balloon. We have many of these on the market. These are multiple of them, and even now we've come down to 0.75. And these are very, very nice balloons and low crossing profile that could help you in some of these cases. Of course, you need to know the crossing profile. If that doesn't work, there are multiple other steps. And one thing to say from the beginning, these are not set in stone. One has to be pragmatic rather than dogmatic. They are interchangeable, and there's nothing stopping you from starting from third line approach to first line and combination of everything, and starting from the last resort to the first one. With the first line, usually it's the body wire or anchor wire or a wire cutting balloon. And what that means is this: you could anchor the wire in a branch, what give you stabilization, give you a little bit of a push, so you could pass your catheters and your equipment, or you could put a second body wire next to the wire you have used. And the body wire works by what's called almost like a shoehorn to deflect your equipment away from the wall if there's any friction or any tortuosity. The wire cutting technique is basically putting 2 wires, and you push the wire against the lesion, which gives you, as you can see, where the wire is, and the second wire gives you a cutting effect on the lesion and modifies it. And of course, there are balloons similar to this, like the scoring balloon. That's how they are designed. Usually what's called the Venturi ballooning, when you apply pressure on the balloon, inflate it, then you deflate it quick, and while it's coming down, you push it on, and that also could allow you to cross the lesion. The second thing is you go a guiding catheter extension. There are many on the market, from Guide Liner to Gideon to Guide Zilla, many of these, and currently, of course, the telescope from Medtronic. All these will give you a really huge support. And our procedure has dramatically changed with the guidelines and the way we could use them. And you will be familiar how to use them. You could inchworm them slowly through the difficult arteries using a balloon or a stiff wire, and that helps you to deliver them as distal as you want. After that, you could use a micro catheter, and there are again many of these. We started with the Corsair, which has revolutionized what we do, and now we have the Turnpike, the Fine Cross, and many things, as well as the Turnus. The Turnus is a little old, as you could know. As you know, there are two of them, 2.1 and 2.6 French, which are 8 stainless steel wires wrapped together. So you advance it by anti-clockwise rotation, and you have to release the tension, and you only do like 10, 12 rotation for the 2.1 up to 15 with the 2.6. They are not used as frequently currently. The Corsair and the Turnpike are really very good catheters. As you can see, 2 big braided and 8 small ones. You could advance it by clockwise or anti-clockwise. They started as septal dilators, but now we could use them in uncrossable lesion, and they have helped quite a lot. This is the Turnpike catheters, and there are 3 of them. The normal Turnpike, which now Turnpike LB, a low profile. The Turnpike spiral has that plastic wrap around it, which allows it to hook into the lesion. And of course, the more advanced one is the Turnpike Gold, which you can see the tip almost like a screw, and it is quite effective in up to 75%, at least in our series at which we published effectiveness of this Turnpike Gold. After that, you could use an anchor balloon. Of course, an anchor balloon is much easier to use than a larger bore catheter like 7 French or 8 French. And the anchor balloon could be distal or in a side branch. The side branch is the more common one because that gives you really good anchoring. The distal anchor is usually to deliver a stent, because if the balloon can cross the lesion, then that's crossable lesion, but sometimes the stent might not. And this is where you could anchor distally and deliver your stent, and then remove the balloon before you deploy the stent. After that, if this doesn't work, you could go to a little more advanced technique like the grenadoplasty or Carlino technique. The Carlino is mostly for CTO, uncrossable proximal cab, where you could put your wire and the tip of the microcatheter and inject some dye, very little amount, hard injection, almost creates some cracks. The same with the grenadoplasty. You put your balloon against the lesion and you inflate it to high pressure and allow it to rupture intentionally. And that releases some of the contrast jet that will affect the lesion and cause some cracks, will allow you to bypass it. Of course, if that doesn't work, we have the laser, and laser stands for light amplification stimulated emission of radiation. It's quite effective. It has 3 mechanisms of action: photochemical, photothermal, photomechanical. And it could be effective up to 80% to 85% of cases. It is not the first approach for heavily calcified lesion, but it is very effective and very helpful. Of course, the second one is rotablation or orbital device. Orbit device could work on any angioplasty wire, the 14,000 of an inch, which might give it an advantage. The rotablation require a special wire, which is 10,000 of an inch, so you have to deliver that wire, and that could be a little tricky. And as you know, rotablation has the console and the consumable, the burrs from 1.25 up to 2.5. And again, shaves the calcium very well and prepares the lesion very well. A combination of the two can be used, of course, expensive, but on occasion, less than 1%, it has to be used. And this is, we published a series about this, we call the tracer, where you use the laser to create a channel to pass the rotablation wire, and then use the rotablation to prepare the lesion. Now we come to the most significant or more advanced technique, which is the subintimal crossing technique. And this is basically for really experienced operator, particularly with CTO technique. You have a wire through the true lumen, but nothing's going. So you go outside of the lumen into the subintimal space, where you dissect and re-enter distally, or only just dissect and use the balloon outside in subintimal space to crush the calcium in the lesion. That's uncrossable. And once you've done that, you find that the equipment will pass through the proximal or the true lumen inside the lesion, because it has been modified. And this is, again, as I said, it has to be for people who are familiar with CTO technique and dissection re-entry, because you might have to dissect distally and re-enter distally. So if I put this in summary, as I said, multiple first line, second line, third line, or interchangeable, or a combination you could use, and you don't have to start in 1, 2, 3. You could start from rotablation right on, or you could go first with guide extension, etc. This is a summary of how you do it, and I would draw your attention to a publication that we did with a very comprehensive review of uncrossable and dilatable lesion that you could find free of charge on PubMed if you search under my name or uncrossable lesions. And as I said, this is interchangeable, very effective, and you find that you'll have a great success dealing with these uncrossable and dilatable lesions that we are seeing more and more in our current practice. And with this, I would say thank you for your attention. I'll be more than happy to take any questions.
Dear colleagues, it is my pleasure to share with you today an interesting case that I faced some time ago with unexpected complication. This is a 76 years old lady with a typical angina for more than 10 years, known with hypertension, diabetes mellitus on diet, dyslipidemia, and she's ex-smoker. She was offered coronary angiography many times during these 10 years, but she was afraid and she was limiting her activity, avoiding any intervention. However, eventually she had severe back pain, which required vertebral surgery, and she was unable to walk. So she came to me as a routine pre-op case for pre-op evaluation. Of course, I did the vitamin stress echo for her, which shows significant ischemia in the anterior and inferior wall territories. After long discussion, she accepted coronary angiography because now she was completely handicapped from the chest pain as well as from the back. I used the femoral approach in her case because her radial artery was not good for the procedure. This is the basic angiogram, and you can see here there is a complex LAD lesion. You can see here the LAD has multiple lesions proximal to mid-segment. You can see it better here in this view. I have better views here. You can see here in the left anterior oblique view. And here, I think you can appreciate the longevity and the tortuosity of the vessel. The right coronary artery shows significant mid-segment lesion. So she had two vessel disease. And my strategy was to do PTCE and stent for both vessels immediately after the diagnostic angiography, using a stent which does not need long-term dual antiplatelet therapy to make her ready for surgery within 1 to 3 months because she was really suffering from back pain. So I started the procedure as usual with the LAD, which was wired, and I did one balloon dilatation, preparing the region for stenting. And suddenly, after I did this, the patient had a sudden, strong, jerky move because of her back pain. This unfortunately happened while I was exchanging the catheter, the balloon catheter, over the wire. So the wire came out from the LAD like a whip, and immediately the patient started to have severe chest pain with ST elevation. She became hemodynamically unstable. The pressure dropped from systolic of 140 to 70 in no time, and I was faced with a sudden emergency. So, as usual, what we do in this situation, we try to support the patient hemodynamic by giving fluids and putting the patient on its ropes, but this was not enough, so an intra-aortic balloon pump was inserted. In the meantime, anesthesia was called for help to put the patient under sedation and to stabilize, the respiratory system. And eventually, the patient was stable enough for me to go back and do coronary angiography again to see the LAD and what happened. So this is what I saw. You can see here that the LAD is totally occluded, which explains the ST elevation. And there was an ugly looking spiral dissection with hematoma. I immediately tried to cross the obstruction with a wire, but as you can see, the wire was going through the fourth lumen. Again, you can see this ugly looking dissection. And, at that time, I didn't know what to do. So I had the intra-aortic balloon pump now from the left groin and the guiding catheter to the left system from the left groin. I thought maybe if I visualize the right coronary again from the same left side, I can see some collaterals. So I did that, and there was no much collaterals, but it was with a long shot enough to show me at least what is the direction of the LAD. And eventually, I managed to find the true lumen. I crossed it. I opened up with a balloon. I put the first stent. And you can see here that still, one stent was not enough. Still, the flow is not optimum because of I did not cover with one stent the hematoma. And eventually, I put a second stent, and you can see now that the LAD is back to good flow. So I just worked with optimization by high pressure balloon of both stents implanted. And you can see now the final result. Excellent opening of the LAD with good distal flow. The patient immediately recovered, after doing the angioplasty and opening the LAD, the hemodynamics stabilized. I thought it would be better not to do anything at this time. So I took the patient back to the ICU, stabilized her overnight. And next day, I brought her back to the cath lab, checked the LAD, which was nicely open, with good flow. So I went to the right coronary artery and stented directly. And a few hours later, the balloon pump was removed after doing the second angiogram. The interesting thing that the maximum cardiac enzyme elevation was 45 for the CKMB subthoracic fraction. The patient, another day, she was able to go home in a stable condition, and she was able to come to my clinic in a week time. This is the LAD second day. You can see that the artery is nicely open, and this is the right coronary artery after it was stented and treated at the same time. The first visit of the patient in the outpatient clinic, she expressed her relief for the first time for many years. She said, I did not feel like this for many years because, of course, this pain that she was denying or trying to postpone, the treatment for avoiding the angiogram unnecessarily. 3 months later, she underwent successful back surgery, and she continued to do well with no chest pain or back pain. She did very well. So the lessons to learn from this case, my dear colleagues, is it is very important to sedate patients properly. Don't just give, light sedation like what I did in this case, particularly if the patient is old, particularly if you are doing a complex PCI. If any mishap happened, the rule number one that we all know, never panic, have control of the procedure, try to use all the resources you have. In my case, a little bit of retrograde collaterals helped me to find the occluded LAD true lumen. If you need to use a support device like intra-aortic balloon pump or Embella or whatever you have, don't hesitate to do that to keep the patient hemodynamic stable and reduce the size of insult to the myocardium. I would like to thank you very much for your listening, and I would be glad to listen to any questions. Thank you.
Welcome, ladies and gentlemen, to the next chapter of challenging cases. and my nightmare in the cath lab. My name is Joachim Weil. I'm in Sana Hospital Lübeck in Germany, and I will tell you about a case which started very usual and ended up in a near catastrophe. So next slide shows my conflict of interest, and let's start with the case. So the first admission in our hospital was back in August last year. This was a 67-year-old woman with the inferior ST elevation, myocardial infarction, and cardiogenic shock. In the initial ECG, we saw typical ST elevation in the inferior leads, as well as an AV block 3. Blood pressure was low, heart rate was low, and patient was stabilized and transferred to the cath lab. Post-medical history was interesting because she got infiltration therapy with local anesthesia due to lumbago with sciatica and persistent back pain. So here you see the coronary angiography and the typical closure of the right coronary as expected, and we put in a stent after having in a cutting balloon, and this was a 3.5 times 32 millimeter stent, and we reached TIMI 3 flow, and patient left stable the cath lab. In the hospital, she already had increased markers of inflammation at admission. And you can see CRP was up to 300, white blood cells were over 12. And so we started an antibiotic therapy with piperacillin and tazobactam. A TE was done to exclude acute myocardial endocarditis. And we draw some blood pressure, which then showed in the following days an infection with MSSA. So antibiotic therapy was changed to flucloxacillin, and screening for possible infection was initiated. A diagnostic CT scan was performed. In this CT scan, we saw an abnormal accumulation of fluids between the obturatus externus and the superior gemellus muscle, as you can see here on this CT scan circled in red. So there was a CT-guided puncture revealing no bacteria, but we had already antibiotics in. So there were decreasing inflammatory markers under antibiotic therapy, and the patient was discharged in good conditions of 4 weeks after admission. So the final diagnosis was STEMI and abscess formation in the pelvic cavity. However, 5 days later, the patient was readmitted, and the patient developed high-grade fever due to MSSA sepsis. So we did an adjustment of the therapy to clindamycin and again exclude endocarditis. But at that time, we saw kind of pericarditis with a small pericardial effusion and a highly echogenic right ventricular free wall. CT scan showing basically unchanged local findings with an additional abscess at the right lesser trochanter. So final diagnosis at that time was MSSA sepsis due to persistent abscess formation in the pelvic cavity and post-infarction Bresler syndromes. Patient again was discharged after a couple of weeks to home. And 6 weeks later, so this was then in end of November, patient was readmitted again. And due to severe pain in the upper abdomen and increased markers of inflammation. As you can see on the graph on your right side, the dark line shows you the time course of CRP over the 3 admissions, and the gray columns show you the white blood cell count. And then third admission, they had very high CRP and leukocytes of about 23. So there was also some weight loss of about 14 kilograms in these patients, but no fever was reported. Again, we did a abdominal CT scan, and the result is shown on the next time. Surprisingly, at this time, we saw a big tumor, 4 centimeters in average in the diameter, in the area of the right heart, and you can see it in the front plane as well. So first, not knowing what this is, we did an angiography, and in this angiography we could show that the RCA was occluded, but even worse, it showed an occult perforation of the RCA. So next step, we did a PET CT which showed this occult perforation with surrounding inflammation, as you can see here by the yellow spots around this tumor in the heart. And here you see the front plane was really a huge abscess in this area. So patient was immediately brought to the OR, to the cardiac surgeon, and they saw intraoperatively a pericardial adhesions and an abscess around the RCA. This abscess was removed, and it showed that there was already perforation into the right ventricle and the left atrium. This was closed by a patch, and the RCA and the stent was removed. Patient was then on a prolonged therapy with antibiotics. She survived this operation and was discharged from the hospital in the beginning of January this year. So the final diagnosis in this patient was coronary stent infection with a occult perforation of the RCA and a perforation into the right atrium and the right ventricle. So what are the take-home messages? In patients with fever and chest pain after stent implantation, always think about a possible infection. So broad spectrum antibiotics should be started in this case, covering all these bacteria which are responsible for such an infection, and a diagnostic procedure should be done as soon as possible. Surgery should be considered early in the course of the disease, and the stent should be removed whenever possible. Antibiotic therapy should be administered parenterally for at least 4 weeks or possible longer. However, mortality in these cases with infected stents remains very high. And if you look to the literature, it's up to 40%. And by saying this, I would like to say Sukhan, and I hope to come back to Dubai next year again. And thank you for your attention.
Good evening, ladies and gentlemen. First of all, I must thank Dr. Omar Halak for organizing such an excellent educational meeting in cardiology in UAE and inviting me for this session. So here I'll present the challenges with left main coronary stenting. I'll put my point together with the left main case, which we have done. So a 50-year male presented in the clinic with new onset angina, and the risk factors was hypertension, hyperlipidemia. He had no other risk factors. First time came to the clinic with angina, and his ECG was normal. Echo showed no regional wall motion abnormalities. Stress ECG is strongly positive at low workload, and cardiac markers were normal. This was his ECG. You can see the distal main left main is almost disconnected, and this was subsequently you can see LAD, left circumflex, and ramus intermediate artery. Same as in the Zoom picture. In another view, you can see it more clearly. So it was a very tight distal left main stenosis. In addition, he had stenosis in the LAD and circumflex arteries. And this was after the LAD was wired. This patient was advised bypass surgery as the first option. When he refused, then we took him for angioplasty intervention. The LAD was stented. Later on, LAD to left main area was prepared. And this was his right coronary artery. So subsequently, we intervened for the angioplasty, where the two arteries were wired. Then left LAD to left main was stented, as it is shown in this picture. Later on, through this stent, it was rewired and went through this circumflex. Typical steps of kissing balloon, and port was finally done for the left main area, which can be reconfirmed very well on the stent clear slide, which showed this fully expanded stent. And this is shown as the final result, which is showing good size left main stem and no residual distal left main stenosis or ostial LAD or circumflex narrowing. He was taken in second stage for after 6 weeks for the right coronary artery stent and left circumflex artery stenting. It will give us an opportunity to check whether previous stenting left main and IVUS study was done to confirm the good diameter which was obtained. PCI left main with triple vessel disease, safe stage procedure without the surgical backup. The culprit left main stem LAD in the first stage for the new stent onset angina was done. Mid LAD stent was placed. Left main stem stent full expansion port was done at the end. And at second stage, check the status of left main stem and full apposition of the stent by IVUS imaging after 6 weeks and PCI of the residual stenosis and LCA and LCXRT was done, thus reducing the risk of complex multi-vessel disease, triple vessel disease with left limb coronary artery can be safely done in this manner. Some facts about the left main stem stenosis. Incidence of a significant left main stenosis, which is more than 50%, is 4 to 6% during routine angiographies. Left main disease occurs with other coronary artery disease in 80% of patients. Bifurcation stenosis were more severe and difficult to handle as compared to the proximal left main lesion. Medical treatment mortality in left main is reported to be 30 to 50% over 5 years. The more severe the stenosis, more than 90% greater is the risk, and as it is more obvious if it is at distal end. These are our experience with the left main coronary stenting. This busy slide shows the patient's age for variable from 25 to 81 years, and most of these patients had LAD and additional vessels involvement. And you can see that there's the left main artery. In another case, this is the ostial left main artery, which is localized. In addition to a diagonal disease, you can see another view. And this was during the placement of the stent and deployment. Another wire was kept in aortic sinus, which give us a marker to put the stent opening. And this helps to delineate or position the stent well, as it shows after the dilatation, full expansion was obtained. So, two stent distal left main is almost a must if there is a stenosis and two left main starting the ostium of other arteries like Medina 111. Depending upon the involvement of the side branch, angulation of the side branch, decision is done. Procedures like T-stent, crush, or pollute have been used in the second with kissing balloon inflation at the end. As planned, severe stenosis in one of the branch or diffuse disease or dissection, then obviously we end up putting two stents. Wider the angle, the 90 degrees, T and protrusion or tap technique is preferred. Studies have found no difference at 2 years of MACE between T-stent, crush, or V-stent. In ESAR left main 2 trial, everolimus and zephylimus stent showed similar end results. So this is another patient with the left main with multivessel disease, where usually left main to LAD was dealt with. Both the arteries were wired, and the kissing balloon was done between the circumflex through the and the LAD, and post stenosis shows a good opening of the left main and ostium of the left arteries in the system. And it can be confirmed very well by the stent clear software or stent boost, which can be seen in this way, the fully extended stent. And that was the result where the balloon was kept for the pot in the left main, and this was the final result. So Syntax was a trial which compared Texas stent with cardiac surgery, and it showed that high score of more than 33 years had lower mortality and lower target vascular revascularization with bypass surgery as compared to PCI. While low to intermediate syntax scores 0 to 32 had lower mortality as well as stroke rate in PCI, lower stroke rate in PCI, with no difference at rate of revascularization. So the study was, however, underpowered to draw any definitive conclusion. This results in provided acute pause for the design of larger trials. Subsequently, this study was done, which showed designs compared with the bypass surgery in 2,000 patients, and the primary endpoint was combined endpoint of death, stroke, and myocardial infarction at 3 years. Secondary endpoint was combined endpoint at 30 days and combined endpoint plus target vascular revascularization at 3 years. And what they found, the primary endpoint, there was a non-inferiority of PCI when it compared to surgery. The 3 years combined endpoint, including target vascular revascularization, again showed non-inferiority. However, the ischemia-driven revascularization was more common during the angioplasty. Another trial, Noble, which these two studies come near the same time, Biolumis, which was the biometric flex stent and left main stenting versus CABG study, it showed higher MACE at 5-year follow-up with the stent as compared to bypass. And most of the revascularization was ischemia driven, and target vascular revascularization was the major difference between the two studies. If we compare Excel and Noble, there was non-inferiority of PCI to CABG and Excel, while Noble showed superiority of bypass surgery over angioplasty. If an Excel versus Noble inclusion of target vascular revascularization is added into the Excel study, then it shows there is a no non-inferiority of PCI, but after adding target vascular revascularization, CABG becomes superior. And as Noble was already, it was superiority of the CABG was seen. So in fact, if we compare these two, Excel, PCI non-inferior or preferred to CABG for more than 50% stenosis in left main with intermediate symptom syntax score, which is less than 32, and distal stenosis using 2 stents. Noble CABG was better when PCI was dealt with more than 70% and less re-procedures at 5 years after bypass surgery. High syntax score, less suitable for left main and multivessel PCI. Some facts about the left main. Left main bifurcation, carina high shear stress area, low atheroma deposition. Lateral valves have a low shear stress and more atheroma deposition. Longer the left main, more is the pressure drop, lower is the shear stress, leading to distal less plaque. And if the stenosis distal was more often than the proximal. Distal left main plaque extend commonly left main. IVUS has been very useful device to see the proper deployment, proper apposition of the stent struts, and fully opening of the artery, which results in long term. Has been shown, there has been evidence of reduction in restenosis rate and routine use of IVUS as a tool for improving outcome in PCI. And more so it is important in left main. Routine follow-up coronary angiography, not needed in most patients except those with high risk. Routine follow-up exercise testing is recommended only in symptomatic patients. And aggressive risk factor modification is essential and can significantly improve the long-term outcomes. So current verdict for left main PCI, ACC and AHA as well as European Society both recommend that CABG as a treatment of first choice for unprotected left main patients who are good candidates for surgery. While PCI for higher risk surgical patients with a syntax score of less than 32 is acceptable option. The most serious complication of death, MI, strokes occur in around 1% of patients, ranging between 0.3 to 3%. In conclusion, analysis of all 5 randomized controlled studies that involved unprotected left main in modern era involving 5,000 patients showed no difference at 3 to 5 years in MACE, while revascularization rate was significantly lower in CABG and stroke rate were lower in PCI group. When considering all trials reported, PCI appears to be safe alternative to CABG bypass surgery. Treatment has to be tailor-made according to the lesion characteristics, comorbidities, and acute and chronic presentation status. So left main intervention are like walking on a rope. When carefully conducted, the reward is enormous. Otherwise, we all know. So good thoughts and action never produce bad results. Bad thought and actions can never produce good results. Thanks.
Good afternoon, everybody. Thank you very much to 40S organization and especially to Dr. Omar Halak for the kind invitation to participate with this challenging case. It is entitled Dual Approach for Percutaneous Closure of Complex Coronary Fistula. I'm Dr. Moreno Samos, presenting this case on behalf of my former team in Salamanca, Spain. I do not have any potential conflict of interest regarding this presentation. This is a 70-year-old patient with hypertension, paroxysmal atrial fibrillation, and early dementia. And because she was living in a mental institution, and he was referred to us because persistent angina despite optimal medication. The angio revealed a large and tortuous coronary fistula from the right coronary artery to the left pulmonary artery. In this other projection, we can also see all these complex network of branches heading to the drainage of the fistula. After a heart team discussion, a decision was made to perform a percutaneous closure due to this frailty and dementia. Using an extra backup 6 friends as a guiding catheter and with a whisper wire, we managed to reach to the distal part of the vessel. And then we use a Provith microcatheter that is here in position to start deploying the coils. This is the first one. We deployed consecutively 5 different coils to close this vessel. The coils were Hilal and Tornado. After that, we closed the main vessel, but all these branches, all this complex network was still intact and heading to the pulmonary drainage. And we waited for some time and was still there, because they can recanalize and form a large vessel. Then we changed our approach. Then we used the femoral vein to go all the way to the right atrium, the right ventricle of the pulmonary artery, and using anterograde injection from the right coronary artery, we find the way to enter in the fistula, in the distal part. At first, we use an EVU catheter with a Sion wire, but we needed this Agilis steerable catheter due to the difficult to to engage and to angulate in this distal part. After that, a 6 millimeter unplugged vascular plug tube was deployed successfully. We can see here the control angio that was good result from this point of view, and from the other part, we injected in the coronary artery, and we can observe here the complete close of the fistula. Very good result. Patient had an eventful recovery and still without any angina. In the follow-up, we performed a CT scan that confirmed that the fistula was closed. So in conclusion, the coronary artery fistula is an unusual anomaly, mostly congenital, and usually is asymptomatic for years until the cardiac ischemia or heart failure appear. The percutaneous closure in selected cases can be an option for these patients with high success rate, few periprocedural complication, and a quick patient recovery. Thank you very much.
Great, thank you. My talk today is on in-stent restenosis mechanism and treatment. So the in-stent restenosis is reportedly seen in between 5 and 12% of all cases. Not all of it is exclusive, but in-stent restenosis is defined as greater than 50% angiographic narrowing. Of course, with the advent of drug-eluting stents, this prevalence is significantly lower than it was in the time of bare metal stents. The ESC recommends that in patients with in-stent restenosis, that either a drug-coated balloon or a drug-eluting stent have a 1A recommendation. In patients with recurrent episodes, where they have diffuse in-stent restenosis, then consideration of coronary artery bypass graft surgery should also be made for the patient, and this carries a 2AC recommendation. The one thing that has changed, and I think is important, is that an imaging modality, either IVUS or OCT, should be considered to determine the mechanism of the cause of restenosis. And whilst this gets a 2AC recommendation, I would say to you, as my talk will say, that this is a really important aspect when managing in-stent restenosis. So how should you diagnose it? So for this reason, imaging is absolutely mandatory when you treat patients with in-stent restenosis. And the treatment is therefore a second stent-in-stent with a drug-eluting stent or a drug-coated balloon. As I've said, both have a 1A recommendation, and the guidelines now recommend that imaging is mandatory for such patients. The advantage, of course, of putting a drug-coated balloon is that it avoids an additional metal layer. And it's good to do this where the stent is not underexpanded. Where the stent is underexpanded, and I'll talk about this later, it makes sense to overexpand, or rather expand that stent to its nominal size of the vessel, and this is where imaging becomes absolutely paramount. The one thing that is becoming increasingly important is that if you are going to use drug-coated balloons, you must remember that the balloon is only designed to deliver the drug. It would be better to refer to it as a drug delivery balloon than a drug-eluting or a drug-coated balloon, because its purpose is to deliver drug. You must prepare the lesion beforehand if your intention is just to use the drug-coated balloon. And this means using vessel preparation with a high pressure or scoring balloons, such that the residual stenosis is 30% or less before you deliver the drug. There are classifications for the in-stent restenosis, and the most common one used is this one reported by Waxman, where you can have type 1, which is mechanical, and this is typically stent under expansion or due to stent fracture. If you see this on imaging, and I'll show examples of this later, then the treatment for this is high pressure balloons and or the use of lithotripsy if there is a lot of calcium, and under expansion is treated before you think about putting in another stent or a drug-coated balloon. My personal advice is that if you see stent under expansion, is that you should expand with a high-pressure balloon and make this nominal, and to create a residual stenosis of less than 30%. Type 2 definition is that of a biologic cause of your in-stent restenosis, and this is typically due to neointimal hyperplasia. You can have neoatherosclerosis or a mixture of the two, and the neoatherosclerosis can also be calcified, as you see in native vessels. With neointimal hyperplasia, the options that you have for treating are drug-coated balloon or drug-eluting stent. And likewise, if you have neoatherosclerosis as a cause of your in-stent restenosis, then DCB or drug-eluting stent are options. There are type 3, 4, and 5. So type 3 is a mixed pattern where you have a combination of a mechanical and biologic etiology, so that you can have stent under expansion or stent fracture leading to neointimal hyperplasia and or neoatherosclerosis. Of course, you can have chronic total occlusion, and this is that diffuse type of neointimal hyperplasia typically that you see leading to chronic total occlusion, and this is particularly difficult to treat percutaneously. You can have in-stent restenosis due to previous 2 layers of stents, and in this, all of the options for treatment are between drug-eluting stent and drug-coated balloon, and you may use intravascular lithotripsy as imaging dictates. Remember, angiography alone cannot identify the mechanism of in-stent restenosis. As I've said earlier, intravascular imaging, either IVUS or OCT, are essential to identify the cause. And once you've identified the cause, you can identify the right treatment. OCT has higher resolution, of course, and in my opinion is superior to distinguishing the disease process, particularly for characterization of tissue type. And it's also easier to see the number of stent layers because of its higher resolution. It is important to identify mechanical from biologic cause. And here I'm just going to give you some examples of IVUS and OCT and the different mechanisms for in-stent restenosis. So here you've got neointimal hyperplasia, and the key here when you have imaging is that you see a homogeneous, bright, uniform layer in the IVUS to the left and in OCT to the right. You can see here in the OCT, the stent is much more clearly visible than in the IVUS imaging. With neoatherosclerosis, the key to remember is that you have a non-homogeneous appearance in both IVUS, as seen by the red arrow. So you have these echolucent areas, which are lipid, and in the OCT also you have these lucent areas, which are the lipid layer. And this tells you that if it's non-homogeneous, then it is likely to be neoatherosclerotic. This is a very good example of how stent under expansion is seen. So here you have the cross-section in IVUS, severely under expanded stent, and also in OCT with multiple, you see 1, 2 stent layers and an under expanded inner stent layer. So once you see this, of course, the first step here would be to use a non-compliant or a scoring balloon to try and expand this stent layer optimally. There is now considerable trial evidence of benefit in in-stent restenosis. I won't go through all of these trials in detail, but you have now stents that compared plain old balloon angioplasty in bare metal stents You have use of drug-eluting stents, paclitaxel in bare metal stent ISR. You have trials comparing drug-eluting stents, everolimus in bare metal stent ISR, and more latterly you have comparison of Taxol-eluting drug-eluting stents versus Taxol-eluting balloons. And all of them show the benefits of treating ISR with a second option, with a second drug delivery option, whether it's on stents or balloons. So, as I've emphasized, optimal lesion preparation is key. And this algorithm reported in JACC intervention by Jaeger et al. Nicely sums this up. So you must pre-dilate using semi-compliant or non-compliant or scoring balloons. You also have the option of rotablation, lithotripsy. You may not do coronary physiology, but imaging is mandatory. If you have an acceptable angiographic result, i.e. residual stenosis of less than or equal to 30%, you may decide to do FFR. It's not mandatory. So one of the two, or FFR less than 0.8, you can then go to drug delivery with a balloon or a stent. My personal preference is to use a balloon to avoid a second layer of stent. If you have a suboptimal angiographic result, i.e. there's a flow-limiting dissection, or the residual stenosis is greater than 30%, or the FFR is less than equal to 0.8, i.e. there's a suboptimal result following lesion preparation, then the advice is to use a drug-eluting stent. And this is very, very useful algorithm, which is both practical and useful. So in summary, in cases of in-stent restenosis following a bare metal stent or drug-eluting stent, the ESC has a 1A recommendation for either drug-coated balloon or drug-eluting stent. It is essential that you use imaging to identify the mechanism of the in-stent restenosis, because the mechanism will help you to guide the most optimal strategy. Whilst you have the option of a balloon, in my opinion, that is advisable to avoid a second layer of stent. In some cases where the balloon may not give you the less than 30% residual stenosis, you have the option of using a stent. The one thing that is becoming increasingly evident is that lesion preparation, if you're going to use a DCB, is absolute key. And DCB, remember, is for drug delivery only. Thank you for your attention.
Good evening, everyone. It gives me a great pleasure to be here in participating in this prestigious 40s meeting. I would like to thank Dr. Omar Halak for inviting me to this prestigious meeting and for the organizing committee. I hope this case will be of benefit to you all. There has been some issues in moving the slides, but I will do it manually. This is a female patient, 74 years old, a typical high-risk patient with diabetes, hypertension, and dyslipidemia. And she's also obese and has a COPD and a renal impairment. She came to the clinic complaining of frequent anginal attacks that increased in severity during the last 2 weeks. And there is history of sudden death of her younger brother. The ECG showed significant ST depression in all ventricular leads and inferior leads. And the ECG showed normal ejection fraction with a segmental motion in the LAD territory. And her lab showed a moderate impairment in the renal function with a creatinine of 1.9 and an estimated GFR of 40. Her LDL was high and her hemoglobin A1C was also high. She was not a very obedient patient and she's obviously not well controlled. Her coronary angio was decided and it showed a diffuse ostial disease, an proximal disease followed by mid-segment CTO, which was a rather long segment CTO with a GC score of 3. The CX showed diffuse distal disease, and the right coronary shows both a proximal critical lesion and an ostial PDA lesion. I will do it now manually because there was, okay. You can see here the distal circumference disease, and the LAD doesn't show actually in this way, But here in the spider view, you can see the ostial LAD disease and the diffuse disease, significant disease in the intermediate branch, which is a small diameter vessel, and the distal circumflex disease. You can see here in the cranial view that the occlusion was rather long, but there was some antegrade flows here in the LAG, in the distal LAG, and it was also obvious in the epicranial view. You can see it from here. Sorry about that, but I have to do it manually. And this is the right coronary. The right coronary showed a critical proximal lesion and a critical ostial PGA lesion, as you can see it now in this view. You can see both the critical proximal RCA lesion and the critical ostial PGA lesion, and there was retrograde filling of the distal, maybe 2/3 or distal half of the LAD. So there has been a great discussion with the cardiac surgeons, and the syntax score of this patient was obviously very high, 34, and the syntax 2 score was equal to CABG, and the logistic Euro score was high, 7. And the discussion point was what is the best strategy for this patient, whether it's surgery, PCI, or even medical treatment, which we sometimes resort to. So because of the renal dysfunction, the chest condition, and the short obese patient, these kinds of patients that always surgeons refuse, and also added to that, which is not the main issue, but her family were totally against surgery. So PCI was decided, and the second step was to whether to start with the right coronary or the left coronary, whether to do it all in one session or in a staged procedure. So I decided a staged procedure starting from the right coronary. The procedure I did with a PT2 wire. Right coronary was rather technically simple, but actually a very serious one because she was living with this right coronary. A 2.59 compliant balloon was used for dilatation of both the ostium of the PGA and the proximal part, and then a 3.5 millimeter by 33 Zions Alpine was used for the proximal part, and a 2.523 in the distal part. Then a pot was used. I will try to go rapidly so not to waste time because of this kind of manual thing. But this is the wire crossing both lesions. I will try to skip some parts. This is the balloon used for dilatation, both in the proximal area and in the distal area. And this is the balloon in the proximal part. And this post balloon thing, but I will show you the final shot before. And this is the first shot after putting the stent in the proximal part. And then the other stent was put, and this is the pot done. This is the stent in the PGE ostium. This is the final result of the right coronary. So the patient that you can see the timing was at August this year, last year, and this was her final result after the right coronary. The patient actually did very well, but she was still having some anginal pains. But you can see here the result in the right coronary was fine. So 2 months later, or maybe even 6 weeks later, we did the angio to planning to open the stent in the occlusion in the LAG, and you should follow the steps as I show you now. You should put your workhorse wire first, This is the workhorse wire over a microcaster, and then you remove the wire and put them along with the microcaster in place. And then, which I usually use, I use the Gaia second, is my favorite wire in CTOs, especially in long segments. The Gaia second rarely fails in crossing such lesions, and actually it didn't fail me in any case, but sometimes we use Gaia third, sometimes I use Filter XT, but in this case, I used the Gaia second. It passed progressively into the lumen, and you can see here that it successfully crossed distally, as I will show you now. The wire is passing smoothly downwards because at the distal half, starting from here, the vessel was okay. I didn't show you the checks from the retrograde, from the RV and from the right coronary injection, but then the next step was to exchange this wire and to put the microcaster advanced distally and to change this wire to the workhorse wire again, which is my wire is PT2, after wire entrapment using a balloon 2.5 by 12. This is the wire entrapment technique. You can see here the balloon inflated, and we can see that we can exchange the wire by pulling the microcaster back. And this is the balloon used for dilatation across the lesions. The balloon used everywhere. I'm trying to skip the balloon injections. And then Zions 2.538 stent was put. You can see here the waist is there. And then another stent was put in the proximal part here. This is the second stent, 3.33. So we are now left with the left main. This is the overlap. No need to move it. And this is the result after the two stents. You can see obviously the LED is fine. The distal part of the LED will definitely grow. It's okay, but will grow up by time because of CTO. So what we were left now is the left main, and what to do in the left main. So I decided to put 3 wires, one in the left main, the LED, one in the intermediate branch. Although I was not planning for dilatation, but I think that it's obvious that we have to protect this branch from occlusion. And of course, the third wire would be in the circumflex, of course. This is the wire manipulation. So we put 2 wires. And this is in the circumflex and LED. And this is the third wire into the intermediate branch, just to be marker for it and to save it from occlusion. I will not do anything for it, but at least to save it from occlusion. Then I did balloon dilatation. Any osteal disease, you have to do balloon dilatation for debulking. And then this is the stent, a 3.5 by 38 millimeter stent. And then there is the pot. I just want to elaborate on the pot, that the distal part of the balloon, you see here the pot, the distal part of the balloon should be at the distal part of the bifurcation, not at the proximal part. This is very important to allow proper access to the circumflex and to allow also opening of some of the struts to the ostium of the circumflex. This is very important point, and this is the injection, the inflation of the balloon, and this is the result in the spider view, which is okay, and we didn't lose the intermediate branch. And this is the result from the whole LED from the left main. You can see now we have a good LED, and we have previously done the right coronary. So the patient actually is fine, and she's doing fine. I met her just a week before this presentation, and she is okay. Her echo went back to normal, and there was actually no segmental motion abnormalities. My take-home message, Mr. Chairman, is that complex PCI is always a great challenge. Hard team discussion and decision is a must. Staged procedures could minimize the challenge of total revascularization with multivessel disease with renal impairment, and actually her kidney function was okay after a staged procedure. With the right tools, which is very important to use the right tools, the microcatheter, the wires, the dedicated wires are not the workhorse wires, and the high level of experience of operating team, difficult anatomy can be efficiently handled. Thank you very much, and thank you for allowing me to participate in this prestigious meeting. Thank you.
Well, this was a very rich session today. We have a lot of kind of challenging cases, and definitely I personally learned a lot of things from this meeting, and would like to have opened the discussion for if we have any from the audience, or otherwise the panelists will have some questions.
You know, Dr. Omar, I just want to say that I wasn't able to introduce all of these amazing speakers from all over the world, the USA, UK, UAE, Germany, Spain, and Egypt. And I just want to thank each and every one of you. I do have a question. I want to thank Dr. Adel for that last talk and Dr. Ahmed for the first talk. He was having some trouble dialing in, so I think he's there. But Dr. Adel, such an elegant explanation of how we can really attack these multi-vessel disease and, you know, really save the patient from bypass, especially when they don't want bypass. I see, as I come to the UAE, a lot of patients are really resistant, you know, to going to the surgical suite, but really having this ability to help them by stage procedures, I think that was very elegant, and thank you very much for that.
Yep.
I think you said something. I think you're muted. What are you saying? Unmute yourself.
It was a great case, Dr. Adel. Really very challenging case. Excellent result.
I have history on the background of Egypt. I just want to show you some of these pictures. This one is the Baron Palace, which is the first palace to be built in the Heliopolis area. And this is the first Egyptian president, Hamad Naguib, in the background. So I'm here surrounded by history.
The giants.
Yeah.
Thank you so much.
So this is a VIP room. You are in the VIP room.
I'm in a hotel actually for another meeting, Cairo PCR. It's in the same time.
Okay. Okay. Well, it was a great, excellent end result. Was really good. It's like a brand new artery at the end. I know it took a lot
Thank
of
you, Omar, for inviting
work.
me.
Pleasure to have you. Pleasure to have you.
I want to take it to the youngest cardiologist here, I think Dr. Ahmed, but I can't find him. He was having some phone issues. And but I do want to talk about his great case about, you know, coiling those aneurysms. So we know now in the era of COVID-19, which is what I'll be talking about later tomorrow, and I'm not talking about a coronary aneurysm, but he did speak about aneurysmal dilatation in the coronaries and how they attacked that with the coiling. What do you all think about in COVID-19 post-COVID syndrome with aneurysmal dilatation of the coronaries? Do you think that we'll be seeing a lot more coiling of these arteries in the near future for these type of patients?
So Annie, when we've seen these types of cases, I've typically just stented across the very tight lesion. And then if you repeat CT coronary angiography rather than invasive after about 3 months, you find that as the stent is endothelialized and because of restriction of flow, the aneurysm thromboses off. So, yeah, so and it starts to shrink, and it's quite remarkable. I followed 2 cases now, and after a year, it shrinks. So I would question the need to coil it at the time that you place the stent, and I just wondered what the other panelists would say.
Well, I think it depends. Sorry.
Go ahead, sorry.
I was going to say, it depends on what kind of aneurysm you're talking about. The case that presented certainly cannot be treated. You could put a stent in, but you could see a neck into the aneurysm and quite a very limited area of blood spurting. We're talking about an aneurysmal dilatation, the whole artery. Then yes, if you put the stent, the rheology and the flow of the blood changes, then aneurysm will regress. But the case that was presented, I don't think it can be treated without coils. The other option, of course, you could do, particularly nowadays, you put a drug-eluting stent in, and you put a covered stent, one of the new covered stents that are thin, and the rate of restenosis is quite very low with these stents. Of course, with covered stent, there's always that possibility. But that's something in big arteries you can consider.
Yeah, it is the only problem with the covered stent is off-label use.
Yes, of course.
But otherwise, it works very well. But the thing is, the question for the panelists: what size of the aneurysm you think you have to do something about it? I mean, you have to coil it, or you have to do some action. Any particular size you worry? Have you heard of rupture coronary aneurysm? Any particular size, or anybody have any idea?
Well, it's not the matter of size, it's a matter of having a clear neck, because if you have a clear neck, then you have the ability to close it. But if it's a huge aneurysm, then surgery is the only option, or a covered stent. I like what Egrid said about having a drug-eluting and a covered stent, because this...
Well, that's in fact, actually, even in perforation cases, I always try to put the covered drug-eluting stent first to give you the drugs against the wall, and then you put the covered stent inside. Yeah, I mean, I have a similar case, which is we monitored with the CT scan over 6 to 12 months, and the aneurysm is kept growing, almost the same as what was presented, and we ended up coiling it. However, during the coil, one of the coil migrated into the LAD. Of course, it was inside this, and that is the thing that has to be really...
So this is my concern. I mean, how much is there symptoms because of the stenosis, because you get post-stenotic dilatation, which leads to aneurysm, and the risk of coiling and having the coils go into the LAD is, in my opinion, not a risk worth taking.
But as far, you're talking about two different kind of aneurysm. The aneurysm that was presented, the one I treated, is a proper aneurysm. The one you're talking about where the whole artery dilates, and that's post-stenotic or pre-stenotic, and that's different. If you put a stent, the rheology does change. Excuse me, and the stent does regress. This one we discussed it with the surgeon, and we monitored with CT scan, and the worry was because it was growing that it could rupture. And of course, in that case, we ended up having to put a covered stent because it was a hairy coil, and of course that's really a thrombogenic. So with a drug-eluting stent and a covered stent to isolate it completely.
So if when you coil it, do you put the stent first and then you go through the stent to coil to decrease the chance of the coil coming back to the main artery?
I've done 3 cases so far, and no, I didn't put the stent. I only had to put the stent in the last one where for some reason, again, it was, I don't want to say, but the patient coughed and moved, and that's where the microcatheter moved out. But
yeah, I have a couple of cases before, as Dr. Asfar said, just putting a stent in there. Sometimes actually, if the ostium is very small, and when you put the stent, sometimes it can seal actually. Just simply put a stent and it seals sometimes.
Yeah.
If it doesn't seal, I put some. If it doesn't seal, I put some coil on it, and it usually works. Yeah.
I have
a question for Dr.
Can I share one experience with this? I had a case for this aneurysm. I used a covered stent, and as luck would happen, after 3-4 months, he came back with another ACS episode. And when we decided to do another angiogram, and to my surprise, we found this stent was absolutely clean, and there was no restenosis. As you are putting a drug stent, drug-coated balloon or a stent before, and then putting this thing, maybe to reduce the endothelialization. But probably because the stent is covered, the endothelium does not come into the lumen. So I was always scared. Its only risk is the thrombus, not the endothelialization.
Yeah.
So I think we had a false fear that without drug, this stent may have a problem of higher restenosis, but that was not the case.
Yeah. One thing, an important point here that to mention, if you are going to coil these aneurysms, you really have to really pack them with lots of coils. That's what was done in that case.
That's my concern. How many actually coils, in this case, Ahmed presented?
I think Ahmed, he did too many coils.
14 coils.
Apparently, the coils were on sale, and that day they were on sale, so they were.
Okay, now
I had similar case, but it wasn't the popliteal artery. It was a popliteal artery aneurysm actually, and at that time the drug coated the coated stent for the peripheral was not available, so I had to put I think I put like 13 coils before the aneurysm was sealed. I have also some cases in the right coronary artery which I use the coils successfully. But nowadays, I try to use a coated stent. I think it is very good alternative, especially if the artery is big. Then it is a good option because you can seal the neck completely without the need to use multiple coils in few minutes rather than keep putting one coil after the other.
Yeah.
Jose, you have a very interesting case actually. It looks like as a Steele syndrome, the coronary flow going to the pulmonary artery and causing angina. I guess that's what was causing the symptoms. But I noticed later on you put a vascular closure to the pulmonary artery. Is that what you did toward the end?
Yeah, our first approach was to deploy all these coils in the right coronary artery.
To the fistula itself, yeah.
Yeah, but just in the same procedure, our thought was that probably this fistula was going to recanalize somehow with all these branches, and then the fistula is continuing causing this coronary Steele syndrome. So I think we waited almost 15 minutes, hoping that the vessel will close. But after that, because all this history of the patient with the dementia and probably was our only chance to close the fistula in this procedure, we changed the approach for this retrograde approach. We have experience with this steerable catheter, the Agilis, usually in the paravalvular leaks that are very in mitral paravalvular leaks that are very in the septal position that you need to go to move to this area with this steerable catheter. Otherwise, it could be impossible to access because the angle was
you close pulmonary artery, right?
Sorry?
Yeah. You did a closure to the pulmonary artery.
Yeah. From the pulmonary artery, we close it with this vascular plug, but with very, very close angle, you need always this stable catheter. Otherwise, it is impossible to access the fistula from that position.
Jose, can I ask you how you assess the patient? What imaging modalities you use to decide that it needed to be closed?
This patient was something special because it was in this mental institution and was referred from this directly because all this agitation during the chest pain and so on and well, we didn't expect to see this complex fistula, so we had to manage how to close it and solve the patient. We have the family outside. We consulted with them, and then we move on to this procedure.
Did you get a chance to do any?
We have our sorry.
Any imaging at all? Did you get an opportunity to do any imaging to assess?
No, not at all. Even not an echo. We performed just a echo fast in the bed before the procedure, and then we didn't have any CT scan or other technique.
Okay.
I mean, the only thing that might help you here is a right heart catheter and maybe measuring the shunt.
Yeah, probably, but the patient didn't have this.
Such a large
fistula like this. Yeah, it was just recurrent chest pain. So no heart failure to think that maybe we have probably a shunt, a severe shunt.
Good. I think it's we are getting to the.
Omar.
I'm sorry?
First of all, I'm very delighted to have Dr. Adil Atrebi,
Thank you.
He's a very close friend, and I always feel happy to see him. Your case was an excellent, case of managing three-vessel disease. I totally agree with your strategy by staging the case into two sessions. However, I just want to know what was your strategy by starting with the right system rather than the left system. The patient has significant, left main LED and left circumflex artery. So was
We
not.
have about 30 seconds left.
Yeah, it was not better to start with the left system. What's your strategy in this?
Well, I thought it's. Thank you, Fikri. Fikri is a dear friend of mine, and see, Egrid also is with us.
Mohanad, yes.
Yeah. So, Mohanad, how are you? Are you fine? It's good
Very
to
well,
see
yeah,
you.
thank you. I'm coming to you soon.
Yeah. Yeah, I know. See you soon. Actually, Fikri, I thought that having the right support from the right coronary during trial of the LAG, because the ostial LAG was also diseased. So I thought if something wrong goes to the LAG with this kind of right coronary disease, then I would be in great trouble and the patient would be at high risk. So I thought that correcting the right coronary first will give me more time and more support to the procedure later on. The message is that you should use the right equipments if you are planning to do CTO. And this is the most important thing. In CTO, you don't use regular wires, you don't use any equipments, use the right tools to do. But it's up to the operator to decide which vessel to start first. I thought this was safer to the patient.
Okay.
Well, thank you so much. Great. That's the reason they put you in the Hall of Fame, Dr. Adil, with the president. So
yeah.
Thank you so much for everybody. It was really great presentation for everybody. It was very exciting cases and presentation. Thank you so much. I wish we have a bit more time, but fortunately we have to go on for the next session.
Thank you, Ahmad.
We'll see you
Thank you.
afterwards.
See
Thank you
you.
so much.
Thank you, everyone. Thank you, Dr. Ahmad. Thank you.
All right. I think we're going to have a symposium.
Yeah, go ahead, Dr. Annie, for the symposium. There will be Dr. I think Engineer Khalid Yunus going to present about.
Right, Engineer Khalid, and we're going to talk about, it's a GE symposium, Revolution in Cardiac CT with Artificial Intelligence. Very exciting for all of us worldwide. Go ahead, Engineer Khalid. I think everybody's gathering here in our Hall A. Our Hall A is quite an exciting place. Here we go.
Hello, Dr. Omar.
Yes, go ahead, Engineer Khalid.
Engineer
Yes,
Khalid,
hi,
we are
everyone.
glad to have you here today to talk about the resolution of in the cardiac CT with artificial intelligence. We're glad to have you.
Thank you. Thank you very much. Thank you, Dr. Omar. Thank you, Dr. Ani. Thank you for this opportunity to allow us to present a great solution for cardiac scanning. I've been listening to all the nice talks, and I hope our part in this, in the term of technology, can add a little bit help to make your life a bit easier. I will share a recorded video. I wanted to be respectful of time, so I recorded exactly 15 minutes. Can you see my screen right now? Are you able to see the screen?
Yes.
Yes,
okay.
we can.
I will start it, and then if there are any questions, you can stop me and I can answer the question. Thank you.
Thank you so much.
Good evening, everyone. My name is Khalid Yunus. I'm the CTE Sales Manager for the Middle East for GE Healthcare. Thank you very much for allowing us to participate in the 2022 40S conference that is being held digitally. And today I will be talking about the revolution and the integration of AI in cardiac scanning.
As we say, and we know that cardiovascular disease is the #1 leading cause of death around the world, accounting for over 31% of all deaths worldwide. And coronary artery disease is the leading cause of this. And this is why the technology of CT had to go through enabling AI to help and complement the cardiac scanning for a more robust and accurate diagnosis to help cater to that need for today and for the future. So, talking about the revolution of cardiac and the integration of AI in the revolution and the cardiac scanning, we have to keep in mind that all the arguments and all the talk about the technology have been catering lately around 16 centimeter detectors and allowing the 16 centimeter to be the gold standard for all cardiac scanning. Why? Because with some of the 16 centimeter detector technologies are available right now, we're able to do one heart rate cardiac scanning at any heart rate, even for AFib variable or high heart rate, being able to do high resolution stent visualization and plaque characterization, all with a very low dose and with very low consumption of iodine, allowing us to do advanced cardiac applications like dynamic myocardial perfusion or one scan, one protocol, TAVI planning for whole R2R data. And allow having one technology and one scanner to do one this is where I want to talk to you about. Of course, we know that the cardiac is the most challenging procedure that a patient can go through, and the cardiac challenges vary from either technology specific or patient specific, and it starts from the scan, prior the scan, during the scan, and even for the reconstruction. And to summarize the main challenges into cardiac scanning, it is based challenges based on acquisition, what protocol, what is the correct acquisition for the cardiac scanning, how is the gating affecting the scanning, what about the patient condition, the weight, the arrhythmia, the heart condition of the patient, am I able always to see the best image quality across the cardiac scan, and what about the motion and the motion of the coronary arteries and the heart, can I overcome these to get this robust solution? And this is where I will talk about. And to summarize, we have integrated AI technologies. AI technologies to solve for these issues in terms of either cardiac autogating, to managing smart arrhythmias and patient conditions, to allowing the radiologist to view the best image quality with the best phase, all done automated based on AI. And when that we have this difficult patient where we have coronary motion, how can we solve for it and not lose the exam, not rescan and inject again? And this is where I'll show you very nice features, AI integrated solutions that available in the market right now. As I said earlier, 16 centimeter is the gold standard for cardiac scanning. And in 16 centimeter, we introduced something new. We eliminated the need to do retrospective scanning with table movement. And this allowed us to have a more robust and minimized coronary motion through the cardiac examination. And even now, with some of the 16 centimeter technologies available in the market, you are able to scan the full heart at any heart rate for all the cardiac examination, all within 1 R2R, having a temporary uniformity that is allowing to have this robust examination. The one-beat auto-gating cardiac is not only for one phase or limited to a selected examination. We can even scan up to 3 separate acquisitions within 1 R2R, like the viewed image on the screen, where we are now scanning at with the auto-gating, the end systole and the systole acquisition within one single beat, and all done with one beat motion-free coronary of a speed rotation of 0.28 seconds, and will show how the motion correction will add to that temporal resolution and give us the fastest temporal resolution available of 24 milliseconds to allow to cater to all the conditions of cardiac scanning. An example utilizing our deep learning AI-based reconstruction engine to able to acquire an image such this one, 0.4 millisievert. viewing the image with only 100 kV and 275 mA, effective dose of 0.4 millisievert. To be able to view an image like this that is uniform without stepping, done in only one beat, it is where the technology is leading us. Also with cardiac autogating, we know that we have different heart rates. We have low heart rates, moderate heart rates, intermediate or even high rates. And it's very difficult to choose, according to the heart rate, the best phase to scan. And with cardiac autogating and the integration of AI, we are able to automatically determine when to scan within the heart cycle. And that will give us a fast and reputable workflow. Will create profiles for all cases that are customizable according to the heart rate for an overall most efficient dose and robust image quality to address all the patients and all the heart rates. And as you can see with the example on the left screen of the screen, lower left corner of the screen, where the system automatically, according to the heart rate, suggests the phase selection automatically and allowing us to ensure based on the patient information and the heart rate to acquire the best phase, the best scan for a robust scan every single time. Arrhythmia management, even for the patient are well prepared, we cannot come over arrhythmia, beta blockers or no beta blockers, and these conditions are common. So with the arrhythmia management that are introduced within the CT technology, some systems are now capable of monitoring the heart rate, monitoring the R to R distance, and being able to avoid scans during the ectopic peaks or the arrhythmia and make sure it is scanning at the correct cycle to cater to image quality issues, motion, coronary motion issues, and allows to produce this image quality. What about high heart rates and multiple ectopic beats and AFABs? Even when the scan is detected that it is scanned at a wrong beat or an ectopic beat, it automatically takes another scan to allow for a confident and robust solution without having to rescan and re-inject the patient. And this is also based on AI technology. An example of arrhythmia, a patient of 74 to 204 beats per minute, the system selected in a perfect way the correct beat to scan, one single beat in one single heart rate. The scan is done with a beautiful image quality and not being missed. Even the patient is 35 BMI, big patient, we are able to get this image quality utilizing only 100 kV and DLP of 261. Another example, one beat CCTA, 80 kV, patient heart rate 95, effective dose 1.7 millisievert, done at in one heart rate, one rotation for a beautiful image quality. Slice thickness of the image is 0.625 and effective dose, as I said, is 1.7 millisievert. So even when we are scanning without problems, we know that we're scanning multi-phase cardiac examination, the standard or the nominal phase selection done by the machine is not always the best. But what about if we are able to find better image quality within the phases without all the manual phase? And that's where AI-based technology, smart phase, is automating this procedure for us, automatically selecting the best phase to reconstruct without the headache of going of manual intervention and selecting and reconstruction each phase to get the best one for the better outcome. An example of this, we see in this example that the normal nominal phase of 45% is not as good as the 41%, where the system automatically detected this 41% and they constructed automatically for a faster worker flow and better image quality and a better diagnosis of the right coronary artery, single beat, coronary specific analysis with wide cone reconstruction, and the selection is a figure of metric base of circulation and edge strength. An example of that, and we know that the variable heart rate is even more difficult to scan than the high heart rate alone. And with the smart phase, heart rate is variable between 80 and 127 beats per minute. The system, first of all, successfully scanned at the correct heart rate and automatically selected the 92 millisecond phase over the nominal 275 millisecond to give us this better image quality, better diagnostic image for the doctor, all done in automated way. Motion correction, and this is the big topic here. Motion correction, even for the most difficult patient or most well-prepared patient at low heart rate, where we are giving the best attention, we are giving beta blockers as soon as the patient goes inside the CT room and feels the injection or hears the gantry noise from the rotation of the CT system. Heart rate will start spiking up. Even at 60 beats per minute, you'll still have this issue where you'll have motion correction. And motion correction can be solved by fast rotation speed, but currently with the current technologies, no system around that can rotate with the required speed of perfect cardiac scanning, which is 20 milliseconds. And this is where smarter solutions in software came to solve a hardware problem for with a software solution. With a software and AI-based solution, we are correcting for motion correction for the coronary arteries and even for the whole heart. So we are not able to scan at 20 millisecond and rotate the gantry at 20 millisecond, or we are now able to, through the process of software and AI-based technologies, to cater and provide a solution that gives us a 24 millisecond temporal resolution based on AI, and to freeze the motion correction, freeze and solve the motion correction even retrospectively, where you have that difficult patient at even the very good heart rate, you will be able to solve it, ensuring this more robust, more confident diagnosis for the normal patient, for the difficult patient, for high heart rate, AFib, and all the other situations that you'll be able to face, and all for one reason and one reason only. We want to get the best image quality, the most diagnostic image quality. We don't want to rescan. We don't want to re-inject. We want to keep the patient safe and have a better patient experience with a more robust. Keep in mind that cardiac scanning, it is becoming a very popular thing. 50% of cath labs can be avoided with a CT because they are finding a non-diagnostic outcome. So if we can cater to the 50% of cath lab that are not needed and do it in a CT in a more efficient way, and this is where the technology is heading. An example of these advanced applications, one-beat auto gating for functional evaluation, is the ability to scan for the whole heart in a single beat at any heart rate with low MA, with fail-safe modes like smart face selection, like motion correction technology, like AI-based reconstruction imaging, where we are able to view the texture of the image in a real way without the penalty of high dosage. Another example, cardiac CT angio, aortic valve of 70 kV. Keep in mind this is done at 1162 MA, so high MA, low kV. Effective dose is 14.4 milligram, which is very low for this cardiac examination. So advanced application, and these kind of applications are not being able to be done through a lot of systems, but with the current CT technologies in the market now, we are able to do CT dynamic myocardial perfusion, and we're able to do and figure out what's happening in the myocardium and look at the blood flow and the blood volume in an efficient way and in a very dose sensitive way. It is helping to us to determine the coronary lesion, the flow limitation, lesions without having to refer to patient to different tests or MRI even.
Doctor, just to be respectful of the time, this concludes the presentation. I didn't want to go so deep into how we do the technology. I wanted to show an outcome of a machine, of a CT that really is changing the game, who's maybe adding to relieve some of the pain that you are getting with a lot of the issues that relates to this cardiac examination. I welcome any questions if you have any questions, doctors.
Well, Engineer Khalid, I just want to thank you for showing the world what GE can do for us, change our life. Actually, all that frustration about getting that heart rate down is gone. I think, single beat analysis and smart phase technology, right? So I think this will make a huge difference, especially Dr. Halak. You are the
Yes,
guru of
definitely.
CT,
This is, I mean, the challenges he already mentioned. Many of the challenges we have: the heart rate, the regular heartbeat, PVCs, arrhythmia, patient movement, patient size. I mean, I'm glad they found this solution for many of the challenges we have. If you probably have 1 more minute left, if you can talk about stent. If you have a stent, what is the AI can help us on a stented artery?
Great question, Doctor. So lately, in just the last year, we have introduced AI-based reconstruction engine, Doctor. AI-based, following the normal technologies that has been around for the last 5 years, which is iterative reconstruction, where a lot of these comments are happening, where maybe I don't like the feel of the image, the noise texture of the image, and how it affects the diagnosis or the anatomy or even the stenting. So this AI-based reconstruction engine is called True Fidelity, where we use the neural network, the AI-based platform, taught the neural network 40 years of high-dose filter back projection images and showed them of what the real texture of the image can be, and applying this to our iterative reconstruction, where the benefit of the iterative reconstruction is the dose reduction. So we're able to lower the dose by 82% with iterative. But imagine taking the iterative reconstruction dose reduction only separately, which is 82%, applying AI-based reconstruction and viewing an image with a true noise texture and a true noise and feel of the image with the dose detection technology. Looking at the stent and the Revolution CT, so this itself, in coupled with the high resolution technology available on the Revolution CT and the metal artifact reduction technology also applied there, we are removing all the beam hardening artifacts from the stenting, visualizing the stents without blooming artifacts. Even if there's a restenosis in the stents, you're able to see it and do your analysis perfectly. And this is, of course, a balance of the technology in terms of hardware, an efficient detector, a high resolution of the detector, and AI-based technology in the reconstruction engine.
That was really great, and look, technology getting better every day, and I'm glad you have it available. And
yes, and 1 more minute, Doctor. We have introduced something just this Arab Health 2022, just last month. We want to take the pain out of the patient experience, out of the radiologist, out of the technologist, and GE for the first time are introducing technologies to can automate the whole process from the pre-scan, during the scan, and even post-scan, not just for cardiac scanning, even for everybody. So we are putting ourselves in the shoes of the customer. How can we relieve you to make your experience better as a radiologist sitting all day reading 20, 30 patients a day without consistency? The patient experience who's going through this headache, we want to make his experience a little better. So we introduced this camera, effortless workflow, where it's automating the whole positioning, parameter selection, protocol selection, all with minimal intervention from the technologists. So it's a full solution, Doctor, to make the lives of everybody better.
Amazing. Well, that's really very exciting and interesting to know. And so I think we get worried about the technician now to find a job. If you can do everything, if the machine does everything, what happens to the technician?
Doctor, I always ask this question, and the answer is simple. We are dealing with real lives here, real patients. AI will never take the job of the technician or the radiologist. AI is
I
here
know that.
only to do one thing: complementing, adding this trust to your job, doctor.
To make the technician's life easier and the doctor's life easier.
100%.
Exactly.
Technician, doctor, and patient.
Thank you so much. It was really very informative and interesting presentation. It brings us really the latest in the AI. The AI in medicine is really the way to go nowadays, and it looks like you have a lot of those add on to your CT scan and make the life easy for the patient, for the technician, and for the doctor.
Exactly.
Thank you so much.
And thank you very much for the time, doctor. Thank you.
Thank you. I guess we are ready for next session, right?
Yep.
We are 1 minute late for the next session. So we're going to ahead and start. And
I think we're going to talk about calcified coronaries.
yes, go ahead and take the lead, Dr.
Right.
Annie.
I think we have some other moderators coming, but I'm going to, in the essence of time, go ahead and introduce these speakers. We have Dr. Evan Schlafmitz from USA, Dr. Javed Ahmed from UK, Dr. Neil Strickman, my friend from the USA Texas Heart Institute, and Dr. Jassim El Hashmi from the UAE. We're going to start with approach to calcified lesions with Dr. Evan from the USA. And we look forward to an exciting conference here with regard to calcified coronaries. Let's do it.
Okay.
Thank you very much to the conference organizers. I'm pleased to be taking part in this great conference. This session will be covering approach to calcified lesions and why intravascular imaging is necessary. These are my disclosures. So lesion preparation is critical whenever we're treating calcified lesions to improve our procedural success. We want to modify the morphology of calcified plaque, and the purpose for this is to ensure that complete stent expansion is achieved. Now, stent expansion is so important because we know stent underexpansion is what's associated with increased rates in stent restenosis as well as stent thrombosis. And this is often occurring in severely calcified lesions. Treating stent underexpansion once it occurs in a heavily calcified lesion is significantly more difficult than preventing stent underexpansion in the first place. And that's why we want to recognize severe calcification anytime it's there prior to implanting a stent. And if we can identify it before implanting a stent, we're able to modify that plaque. Now, historically, lesion preparation with atherectomy has been primarily reserved for undilatable and uncrossable lesions. Over the past several years, there's been a transition to the concept of lesion preparation upfront prior to stent implantation. As we see in 2014, based on the US data, NCDR data showed that there was significant uptick, steadily increasing rates of atherectomy since 2014. But what's notable is a third of cath labs in the US perform zero atherectomy. And we know from intravascular imaging studies looking at systematic utilization of intravascular imaging that imaging changes the majority of decision-making with PCI And a significant number of these changes are focused around severe calcification. As you see here with this example from the Light Lab study, which was presented a couple of years ago at EuroPCR, a third of cases, vessel preparation was changed based on the intravascular imaging. So why do intravascular imaging? Over the next few minutes, I'll take you through the role and importance of intravascular imaging with calcified lesions. And it consists of a couple of different stages. Up first, we have the baseline intravascular imaging run. For this, we're assessing what the lesion morphology is. It's no longer just about identifying severe calcification. It's what type of calcification. And it's important to identify what type of calcification because the type of calcium, intracoronary, really drives what the optimal lesion preparation tool and strategy is. We have multiple devices nowadays. And also the intravascular imaging allows you to localize exactly where you need to apply that therapy. So what type of calcification is there? What do I mean by there's multiple types of severe calcification? What you see from these intravascular imaging cross-sections with intravascular ultrasound or IVUS on top and OCT or optical coherence tomography examples on the bottom, you see side-by-side representative examples of multiple types of coronary calcification. Now on an angiogram, these may all seem similar because this is just a luminogram. But when we go inside the vessel, we see there's different types of calcium, and you have deep calcification, superficial calcium, both concentric and eccentric calcium, and protruding calcified nodules. And each of these can be optimally treated in different ways. We've put together some tools that allow us to assess when lesion preparation is needed. There's both the rule of fives, which is the OCT score. More recently, there's an IVUS guided score, which helps you predict when stent under expansion is likely in the presence of severe calcification if you don't do lesion preparation. The easiest way to remember this is the rule of fives. If you have 5 millimeters of calcium, with at least 0.5 millimeters in thickness in an arc that's greater than 50% of a cross-section, those lesions we know are associated with stent under expansion, and lesion preparation should be considered. Now, there's also newer modalities which are incorporating artificial intelligence, such as with Ultrion's OCT system, which does automated calcium detection. And it also incorporates that rule of five, telling you exactly what the total angle and arc of calcium is, as well as the max calcium thickness. And here we see it gets color-coded. The orange arc represents the regions where there's calcification. Now, to put this all together in an algorithm, we see that by using the information from the intravascular imaging, you can determine what the most appropriate lesion preparation modalities are. And sometimes this is in C balloons and specialty balloons, or intravascular lithotripsy, or the atherectomy modalities. But you can't know this from an angiogram alone. By going inside the vessel and seeing what the calcium morphology is, you can determine what the best lesion preparation strategy is. Now, after you've done lesion preparation with your modality, it's important before you implant the stent to ensure that you've achieved the outcomes you sought out to have. You want to make sure you've ablated the plaque if you've used atherectomy, you've created fractures, regardless of what your lesion preparation technique is. And that allows you to predict that you're going to be able to adequately expand the lesion. This is just one example where figure A is a baseline concentric severe calcification OCT cross-section. In the middle in figure B, we see after orbital atherectomy, we see the concentric shaving of coronary calcification. And this is what helps to facilitate expansion by changing that plaque compliance. In figure C on the right, I see adequate stent expansion in the severely calcified lesion following orbital atherectomy lesion preparation. After stent implantation, as that last figure highlights, it's very important to do a final intravascular imaging run where you can ensure you've achieved stent optimization with full stent expansion. Also ensure you've entirely covered the lesion make sure that there's no procedural complications. As you see here, putting this all together, you have multiple intravascular imaging runs guiding your therapy, and this is allowing you to ensure you've had optimal outcomes. And many people always caution, well, doing these multiple intravascular imaging runs, doesn't this take too long? Well, when we look at the Disrupt CAD3 study, which evaluated intravascular lithotripsy or shockwave in severely calcified lesions, when you look at the OCT arm compared to the non-OCT arm, the OCT arm had a minimum pre-specified of 3 intravascular imaging runs. What's notable, total procedure time was no different compared to the patients who had no intravascular imaging. So it doesn't lead to consistently increased time, but it's better to actually do it right the first time and know that you're achieving optimal outcomes. So to conclude, we know that lesion modification can help to facilitate expansion in the presence of severe coronary artery calcification. This is important because coronary calcification typically impedes stent expansion, and this is what's associated with increased rates of stent failure. Intravascular imaging can be used to assess effective lesion preparation. Thank you very much.
Many thanks to the organizers of 4TS for inviting me to give a talk on hybrid approach to treat calcified coronary artery lesions. I am Professor Javed Ahmed from Freeman Hospital, Newcastle upon Tyne, United Kingdom. Coronary artery calcium tends to be underestimated on traditional coronary angiography. Calcium considered mild or moderate by angiography may be severe if advanced imaging techniques such as intravascular ultrasound or OCT or OFTI are used. Moderate to severe arterial calcium is present in almost 40% of the patients who undergo percutaneous coronary intervention. What are the challenges associated with coronary calcium? During PCI, if there is moderate to severe calcium, the lesions are prone to dissection during balloon angioplasty or pre-dilatation. Sometimes it becomes extremely difficult to fully dilate with the balloon. It may prevent adequate stent expansion and apposition, and it may also prevent stent delivery to the lesion. The different types of calcium include superficial, nodular, and deep. If there is superficial or nodular calcium, then the usual ablative techniques including rotational atherectomy, laser atherectomy, or orbital atherectomy are useful in treating the calcium. And if there is deep calcium, then traditional non-compliant balloons, scoring balloons, cutting balloons, or more recently IVL would be useful. This is just the diagram showing mild, moderate, and severe calcification on both intravascular ultrasound and the OCT. What are the different types of treatments available for treatment of calcified coronary artery lesions? These include non-compliant balloons, cutting balloons, scoring balloons, rotational atherectomy, orbital atherectomy, laser atherectomy, or more recently shockwave or intravascular lithotripsy. Management of calcified coronary lesions remain challenging, with frequent stent underexpansion and suboptimal results, which lead to early and late stent failure. Therefore, appropriate lesion preparation and optimal stent expansion are the keys to prevent stent failure. Two important factors for optimal calcified lesion preparation. First of all, the recent dedicated devices, the calcified lesion preparation is better, and therefore one should consider these devices before planning a strategy to deal with the calcified lesion. The second important factor is intravascular imaging, which is not only important to characterize calcium distribution, but it is also important to optimize spontaneous treatment of these lesions. Therefore, a single plaque modification technique may not be enough if circumferential deep calcium alone with superficial or nodular plaque coexist. It may be necessary to use combination of different calcium modification techniques. When adequate expansion of these lesions with balloon is not achieved, these different calcium modification techniques may be complementary to fracture superficial and deep calcium, and therefore to facilitate stent delivery and adequate stent expansion. What are the combined hybrid procedure to deal with calcium treatment? And I have classified into different modalities. And the first one is combination of non-compliant scoring balloons and intravascular lithotripsy. We can call it balloon tripsy. The second one is rotational atherectomy and laser. We can call it a razor. The third one is rotational atherectomy and intravascular lithotripsy, which you can call it rotatripsy. And then laser and intravascular lithotripsy, you can call it lasertripsy. And finally, if the lesion is extremely difficult, you can combine all modalities, which include laser, rotational atherectomy, and intravascular lithotripsy. First of all, I will start with balloon tripsy. IVL catheter, as we know, has got difficult crossing profile. In most cases of IVL, lesion preparation is required with NC or scoring balloon. This will result not only to facilitate the passage of stent, but it also results in adequate stent expansion. This is just an example of a patient which has got severely calcified distal left mainstem lesion and aneurysm involving the proximal edge of the LAD. So this lesion was treated initially with a non-compliant balloon. This was followed by IVL treatment with a 4 into 12 millimeter balloon, and you could see active IVL. The balloon is being inflated. And now this is the further slide showing almost complete inflation of the IVL balloon, and then a single stent from left main into the proximal LAD resulted in excellent angiographic imaging. The next one is a combination of rotational atherectomy and excimer laser atherectomy. The evidence for this technique and its safety is sparse and limited to small case series and only observation data. Rotational atherectomy is a technique of choice for severe coronary artery calcification to facilitate adequate stent deployment. However, rotational atherectomy could only be used using 4.009 inch diameter wire. Sometimes it's not possible to use the rotational atherectomy wire, and therefore, under these circumstances, a traditional 0.014 inch wire can be used to create a channel through the lesion to permit subsequent passage of a balloon or microcatheter and rota wire to complete the revascularization procedure. These non-crossable or non-dilatable coronary lesions could be treated with this combined strategy. In summary, excimer laser may be indicated as an adjunct to facilitate rotational atherectomy in heavily calcified lesions to permit successful PCI and negate the need to consider alternative coronary revascularization, such as coronary artery bypass graft. This technique of combining rotational atherectomy and laser plays a valuable role in some uncrossable lesions. This is just an example where there is severe calcified proximal LAD and distal left mainstem lesion. It was not possible to advance a rota wire in this lesion, and therefore a traditional workhorse wire was placed in the distal part of the artery, and then laser catheter was used to make a pilot hole into the calcified lesion. You could see the laser catheter here. And after the laser, then you could see there is slightly better flow in the artery. And after that, rotational atherectomy by 1.5 millimeter was used to fracture the superficial calcium. And after the rotational atherectomy, Then non-compliant balloon was used, and finally a stent was placed with excellent angiographic result. So the next one is a combination of rotational atherectomy and IVL. That's what we call it a drill and destruct approach. In balloon untossable calcified lesions, rotational atherectomy is the first line modality to enable operators to advance balloons and stents over the stenosis. If the lesion is undilatable after rotational atherectomy, a hybrid approach, the digital intercoronary lithotripsy, which is called rotatripsy, can be effective approach that further modifies and enables stent delivery. This is just an example of a rotatripsy where you could see that a severely calcified distal left main stenosis along with some involvement of the ostial LAD. So this was treated with 1.5 rotational atherectomy burr, as you could see from this angiogram. After the initial rotational atherectomy, IVL was used, and the balloon was 4.0 into 12 millimeter. And subsequently, after the further preparation with IVL balloon, a single stent was inserted into the left main with excellent angiographic result. Then the next modality is combination of laser with IVL. As we know, rotational atherectomy and intravascular lithotripsy are complementary calcium debulking techniques. Rotational atherectomy ablates intimal calcium and makes a channel that permits crossing of the shockwave balloon, which cannot be easily delivered through sphere lesion. Shockwave intravascular lithotripsy completes lesion preparation, cracking the deep calcium. However, when rotational atherectomy cannot be used for certain reasons, as I will show it in the next angiogram, excimer laser coronary angioplasty in combination with IVL, which we can call lasertripsy, may be useful, as excimer laser facilitates shockwave balloon delivery in a similar fashion as a rotational atherectomy. This is just an example where you could see that there is severely calcified right coronary artery regions. However, it is at a very significant bend and is not suitable for rotational atherectomy. And therefore, in this patient, I used a laser to cross the lesion. As you could see the laser catheter through the guide catheter extension. And this facilitated the passage of shockwave balloon. As you could see the shockwave balloon actively delivering energy to the lesion site and in the process of being fully inflated. After the combination of laser and shockwave, this lesion was fully prepared and a single stent was inserted with excellent angiographic results. You could see this is just imaging before and afterwards. Pre-intervention shows severely calcified lesion in the mid-right coronary artery, and then on the right-hand side this is a post-laser, and then this is a post-IVL, and then you could see full and adequate stent expansion in the same patient. In conclusion, calcium has always been the worst enemy of interventionists. Calcium impedes crossability, expansion, embedment, and coverage. Therefore, combination of different techniques does help in adequate stent and lesion preparation, and satisfactory stent expansion could be achieved, which may help to avoid short-term and longer-term stent failure. In these circumstances, nowadays, the complementary use of intracoronary lithotripsy with existing calcium modification techniques can be an effective approach that further modalities the calcified plaques, that further modifies the calcified plaque and enables optimal stent expansion and implantation. Thank you for your attention.
I'd like to thank the digital audience and the moderator and panel for allowing me to talk at the 8th 4TS conference. I'm going to talk on intravascular coronary lithotripsy, or IVL. I am located at the Texas Heart Institute, Baylor College of Medicine in the US. I'm a clinical professor of medicine at Baylor. I finished my cardiology fellowship in '82 and have 40 years of experience, mostly peripheral and TAVR and some coronary as well. So we will do the following. IVL, what is it? How does it work? Talk a little bit about the Disrupt CAD3 clinical trial, show some cases, coronary and vascular, and then give you a conclusion. So IVL, shockwave, what actually is it? Well, there is, as you can see there, a rechargeable generator attached to a cord which goes to the catheter. It creates sonic pressure waves to modify the calcium. It's a disruptive technology, and it can save the cost of atherectomy. How does it work? Well, here is the rechargeable generator. There is a simple plug and play connector. And then there's a magnet that goes to the catheter that has the emitters. On each end, there's a dummy, and then there are the emitters in between. Now, as you can see, it creates pulsatile sonic pressure waves to modify the calcium, as you will see here. The integrated balloon is expanded normally to 4 atmospheres. Anything more than that will rupture the balloon. So we usually do 2 to 4 atmospheres while we are using the emitters. The fluid in the balloon acts as a coupler to facilitate efficient energy transfer of these sonic pressure waves into the vessel wall. And here you can see what this looks like. There's 3 kilovolts of energy that travels to the emitters from the generator once per second, where acoustic pressure waves pass through the soft tissue, and this impacts both intimal and medial calcium. Now, a small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the pressure waves impacting the calcium at 50 atmospheres, creating a series of microfractures, increasing vessel compliance. And once this is done, then you can move forward with your treatment of choice, whether it be PTA or stent. You can use it in eccentric calcium as well as concentric calcium, probably favored better by the eccentric because more fractures are created. What's interesting is when you do it in the coronaries, you actually get competitive pacing spikes, which I've not seen to be a problem, but you do have to be aware that you're almost double counting your QRS. How about the Disrupt CAD3 clinical trial? They only did heavily calcified coronary lesions, less than 4 centimeters in length and over 50% in stenosis. There was a small roll-in population. There were 384 patients, 30-day, 1-year, and 2-year follow-up. They looked at biomarkers. If you had an ejection fraction that was low, then you were not allowed to be in the study. And again, lesions of 70 to 99%. The vessel had to be greater than 2.5 millimeters in diameter, and it had to have concentric calcium. Renal failure and acute MI were both excluded. Typical baseline characteristics, what's noted here, is almost 70% of the patients had functional class 2 or 3 angina. They were all severely calcified. It is of note that in many cases, 50% needed predilation to allow this IVL catheter to cross. It is quite bulky. It's sort of going back in time to when we had old big balloons. But to get the result, many times you have to predilate. 99% had a stent delivered. The core lab analysis showed that post the stent, there was very few perforation, dissection, closure, and no reflow. I believe that this represented less than 3 patients in each category. The in-hospital and 30-day MACE rate, as you can see, pretty similar across the board. TVR was 0.5% in hospital and 1.6 at 30 days. That's better than just a standard stent itself. The success was achieved as both primary safety and effectiveness endpoints were met treating these patients. It increased vessel compliance. There was a larger post-procedural area and excellent stent expansion. Let's look at some of the cases that we have. Here is an LAD that's quite calcific and very eccentric, for which we used a 2.5 by 20 IVL and then implanted a 3 millimeter stent. Here is a proximal circumflex, very calcified, 3.5 by 20 IVL, and then a 4 by 24 drug-eluting stent with an adequate result. Here is a right coronary, a little bit longer, 3 by 20 IVL, and then a 3.5 by 32 drug-eluting stent. How about some other vascular uses? Shockwave is very popular for the typical adductor canal calcific SFA, as you can see here, very common in the disrupt peripheral cases. Here is a high-grade right innominate, where a peripheral catheter 7 by 60 with 5 emitters was used, 300 pulses, and you can see very adequate stent implant, 9 by 38 balloon expandable stent. How about the left subclavian? Again, Shockwave to give you very adequate stent expansion in the left subclavian artery, and a LifeStream covered 7 by 38 stent was implanted. Calcific carotid stenosis, as you can see here, very concentric, and then we used a 4 by 40 IVL to get a very significant result. There's the wall stent as the final implant. The Shockwave catheters available are 3 kinds: coronary, peripheral, and peripheral below the knee. The coronary has 2 emitters. There's 10 pulses per cycle, 10 seconds for each cycle. So there's 8 cycles, total 80 pulses. What's more important is the size of the peripheral vessel. Here's a 4 through 7 by 60, total 300 pulses. And then the below the knee, 2.5 to 4 by 40, a total of 160 pulses. My conclusions for a Shockwave are as follows. If you compare this to all the other atherectomies, the results of complications is much less, and it saves you the cost of the other atherectomy devices. Take-home message then is as follows. In the Disrupt clinical trial for coronaries, primary safety and effectiveness was noted. Pre-DES implant has an extremely low rate of major periprocedural, clinical, and angiographic complications. Transient IVL-induced ventricular capture can be noted. Don't be fooled by that. It can be useful for lesion modification, and it is rarely used as an end result. The ease of use for cardiologists, it's safe, and time again, I hear my compatriots say, it's just a balloon, and therefore they like it. Well, once again, thank you for attending this digital lecture. As you can see here, I put for you the sound of the emitter, so you can see what it looks like. Again, thank you for attending, and I'll take any questions. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. This is my second presentation, and I will talk about heavy calcified coronary stenosis case presentations. Coronary calcification, I would consider these coronary lesions as a thorny through a thorny road, but crossable. and you need to get your tools ready when dealing with rocks in treating coronary lesion. So case one is a female patient with a known case of diabetes mellitus, ischemic heart disease, coronary artery disease, which was previously stenting with a previous history of stenting of left circumflex artery. The patient had a recent non-STEMI, and echocardiography showed left ejection fraction of 60% with no regional wall motion abnormality, and his presentation, recent presentation of acute coronary syndrome, the creatinine was 8 and hemoglobin 9.8, which is showed a bit anemic, and a troponin of 180. Left side system left coronary system injection showed the previous inserted left circumflex stent, and you can trace the calcification along the left anterior descending artery, mainly in the proximal and partly in the middle segment of the LAD. So preparation of calcified coronary lesion for this patient, intravascular lithotripsy. As you know, there are so many tools available to evaluate and prepare your calcified lesion in the coronary artery. There is intravascular lithotripsy, which convert electrical energy into mechanical energy. There is orbital atherectomy, rotational atherectomy, and balloons. And balloons, of course, you have high pressure balloons and orbital cutting and scoring balloons. So you need to get your tools ready when starting doing coronary artery. So this patient, we started to go for orbital atherectomy and balloons, and it was a CSI diamond 360. And we made mainly orbital atherectomy to the proximal and partially mid RCA. Then post orbital atherectomy, you need to prepare your lesion with balloon. I mean, prepare your lesion more with the balloon, and balloon here can help you how the lesion behaves with the stenting. A long stent with 3.028 millimeter was implanted in this patient. And showed just a proximal part of the left anterior descending artery has some narrowing, but it went well with proceeding with the stenting. Post balloon dilatation of this patient showed a good result, but clearly we can see now there is a proximal LAD lesion, which need to be tackled further. Preparation of proximal lesion by balloon. We have done orbital atherectomy to this proximal LAD lesion. We just need to go with the ballooning. We went with 3.015 millimeter ballooning. And then inserting, it was 3.5, 15 millimeter stent was used to stent this left anterior descending artery lesion, with overlapping of the previously placed stent. Then a balloon with a 4.015 millimeter non-compliant balloon, which is a final pot, was done to the proximal part of the stent, and there was a good result, final result at the end. And actually, it seems that we stented left main with the LAD, so it was a short segment. We involved left main in the stenting, but the end result was perfect, and we are happy. So we prepare the lesion with orbital atherectomy, and then we go for ballooning, and finally we finish with the best result we can get from this patient. So case 2 is a male with a 51 years old, and he's a diabetic type 2, coronary artery disease, and ischemic heart disease. Coronary angiogram showed 3 vessel disease, and heart team meeting went for cabbage, but the patient refused to go for cabbage. This patient has left side coronary artery injection, which was almost always within normal left main coronary artery, and circumflex doesn't show significant lesion, but there is a significant calcification seen along the LAD. It's almost start from proximal to the distal. You think this is a stent, and we asked the patient, have you gone through any procedure before? He said, never. This is my first time I have done coronary artery investigation, and it seems that it's heavy calcification, which almost always circumficial around the luminal part of left anterior descending artery. So the RCA, he has some lesion in the RCA, which dealt before, and then we made the LAD to go for stage procedures. So upon doing LAD, one wire was used for the LAD. This is, we treat the distal lesion with a 2.0 and 12 millimeter NC balloon, and the result was fine. And I think drug-eluting stent, then drug-eluting balloon was used to treat this. For proximal LAD heavily calcified lesion, the most important thing we have noticed that we can know how the lesion behaves with the balloon, and the balloon can give you a good idea about the lesion behavior when starting doing calcified lesion. So this multiple ballooning was done to this patient. This balloon was 2.518, and there is a different views, but it seems that the balloon behaves can tell you where are the area of importance to tackle more with any other tools you have, to either scoring balloon or orbital atherectomy or rotator. Proximal ballooning of this calcified region, and showed this shape, which is commonly seen sometimes in heavily calcified region with a dog bone shape balloon after inflation. Actually, there was escalation of balloon to dilate this part with a 2.5 to 12 and then 3.5 to 12 balloon, but unfortunately, the balloon does not respond. We went further for high pressure with the 3.5, 12. Also higher pressure. The first pressure was 30 bars, the second pressure was 35 bars, but we could not really crack that calcium with these high pressure balloons. Then we had to use one of the tools available in our cath lab. We use orbital atherectomy, and then you can see that after orbital atherectomy, the balloon, which was 3.0, 12 millimeter, was able to open that segment up with a smooth opening, without, sometimes you see the dog bone balloon shape open suddenly, but because of sudden crack of calcium, which can sometimes cause dissection. But while using orbital atherectomy, the end result is really smooth opening of the coronary lesion by high pressure, by non-compliant balloon, and we don't need to go higher, so we went for 14 bars. That's how I want to tell everyone that by using good tools to break down these heavy rocks in the coronary artery, it will be easier later to deal with the balloon. And balloons also initially can tell you where are the important sites of the coronary calcification, which need to be tackled more hard than the other lesions in the coronary artery. Of course, if you don't have IVIS or you don't have any OCT available, so balloons can really give you a good guide. Then stenting was placed in the proximal LAD because the result of almost mid and the distal LAD was fine with the normal ballooning. So we put, I think it was unhappy stent, but it's fine, can load in. So we put 3.5, 18 stent to this patient, and then post dilatation of the stent with the 3.5 to 12 millimeter was placed. So this is the final result, which really accepted with the proximal lesion, and you can see still there is, and you can see there is a stent in the LAD, but I can assure you there is no stent. It's the only stent the proximal LAD, but this is also heavy calcification. So it seems that I think we put drug-eluting balloon for distal LAD lesion, which was there before, and we put proximal stenting just to tackle that area, which was difficult really to pre-dilate with the high pressure balloon. So my take-home message that imaging are great and must, but balloons have an added value. So balloon can help you if you don't have any imaging machine. You can take a short non-compliant or long compliant non-compliant balloon to just evaluate distal heavily calcified coronary lesion. So get your tools ready before start your journey among rocks, because I think you will face so many difficulties, but you should be ready with every tool. Sometimes you can solve the coronary calcified lesion with a normal scoring balloon, or with the cutting balloon, and you don't need to go further. But adding imaging studies will be fine to do this patient, to deal with this lesions. Be ready for complication, dissection, perforation, non-reflow phenomena, etc. And it's not uncommon to have these complications. A patient dealing in dealing with a lesion of coronary artery, heavily calcified lesion. So prepare your lesion, calcified lesion with the balloon and device, and finish nicely after stenting, of course, with the balloon, just to get an optimized result. Don't go for perfect job, because sometimes you will might cause more harm than needed. I think a result of 90% opening or 80 to 90% opening, it will be acceptable for a heavily calcified coronary lesion. And a final message I want to tell, that calcification are hard, but it can obey the rules. So get your tools ready, plan your work, and get the best result for your patient. Thank you very much.
All right. That was a very stimulating session. And I've been in the cath lab with Dr. Strickman when we had those calcified lesions. So just want to give a hail to my professors, Dr. Fraser, Dr. Strickman, thank you so much for being such a big part of our conference here. And that was really nice how you outlined the intravascular coronary lithotripsy, Dr. Strickman. I think it seems so nicely explained. And do you think that it's used enough around the world, or is there much more need for this?
I have to say, I was surprised to see that it's been used so much in the Middle East, because I thought the expense would make it very difficult, because here it's not cheap. So when I saw the case presented by the other physicians, I have to admit I was pretty surprised. Again, it's not the final bottom line. It's like everything else. Over the years, they will refine all of the equipment we have to make
I
them.
think we started using it. I started about 3 years ago, and there has been no stoppage. And we usually combine it with other modalities. And in fact, recently we have just completed over 40 patients of pure unprotected left main. We have just submitted our experience, and the case which I showed was one of those, and hopefully it should get accepted in one of the journals, you see. So it's a great modality. Particularly, the only problem which I have encountered, particularly in the epicardial coronary arteries, including LAD, circumflex, and right coronary artery, is not so much in the left main. It's the passage of the balloon sometimes is so difficult, and you almost certainly increase the expense by having upfront rotational atherectomy. And although you're just creating the channel, but that goes a long way, because the last thing you want is to waste about 1,200 pound balloon, And I think from that point of view, and I usually give it a sort of non-compliant balloon test. If the non-compliant balloon does not pass through a lesion, let's say a 3.5 millimeter lesion, a 3 millimeter non-compliant balloon, here calcium.
All well taken. And I guess the U.S. is always a little further behind everywhere. So I'm glad you had it 3 years before us.
I agree. I feel like we've fallen behind a bit in the U.S., but I find that typically if we are able to pass the intravascular imaging catheter, we usually have good success with delivering the IVL, and that's usually my test. If I can't cross with an IVIS or OCT catheter, I'm unlikely to be able to deliver the IVL there immediately.
Makes sense.
I think in our experience, combining modalities is becoming more important, because the last thing when you start dealing with the calcified lesion, you don't want to leave it, you have to deliver the stent if it is indicated, I think from that point of view, I've combined several cases of lasertripsy where, for example, if the angle is very acute and if there is a sharp bend, I think not suitable for even a smaller bar. And I think having a laser catheter out and then followed by IVL is really useful.
Great.
Can I take it to a different level for you experts there with regard to the coronary calcification? These lesions that you see in the coronary arteries as well as in the carotids or peripherally, are there different reasons for these calcifications? Is it I look at inflammatory markers. I do blood testing for certain inflammatory markers that may go beyond the C-reactive protein. Do you all, in your experience, see that certain types of patients are developing calcification, or what can we do to help in the prevention of that before they get into the cath lab with your really cute little tools that you use?
Well,
that is a very good discussion point.
Difficult.
Difficult.
Yeah, I'm not finding any marker from blood work that I've seen where to really predict that. The patients that you think about this most, CKD patients, diabetics, the older the patient, and with peripheral vascular disease, which makes up more and more of our patient population, basically.
Right.
With technology, with the coronary CT, technology has been significantly improving, where we're able to get a lot more comprehensive information on what the calcium burden is. So it's more than just there's calcium present, but oftentimes with some of the novel CT imaging tools, we're able to get a little better idea to kind of predict if this is a patient that might need consideration for atherectomy or lithotripsy.
Like the depth and breadth of the calcification, right?
One of the patients which I ended up using lithotripsy 3 times actually.
Wow.
We're doing this series 3 times, and that really, unfortunately, 3rd time it worked, and it worked reasonably well. I don't know what is the experience of my colleagues, using repeat lithotripsy, not at the same time, but obviously with interval in between.
We have used it also more recently for underexpanded stents that have come back with restenosis. There's lots of therapies for that, whether you can use laser to increase vacuolization, but we have found that to be fairly useful for underexpanded stents.
Yeah, I think we have been using for underexpanded stent for a while now, and it is helpful. But one of the problems which we have actually encountered, sometimes if it is very, very deep calcium behind the stent, peri-stent calcification, and that is really very difficult not to crack actually with any modality. To be honest with you, laser in blood, laser in contrast, IVL. And I mean, the problem, even if you combine that technique, that is one lesion subset where I have found it incredibly difficult to achieve any meaningful minimal stent area at the end of the procedure.
Yeah, I agree. And the cases where I'm finding IVL most effective for underexpanded ISR is really when there's concentric calcium, because that concentric calcium allows the IVL shockwaves to amplify, essentially.
Do you all think that in this post-COVID era, I'm always asking this question now because this is reality, right? Are we going to see more coronary calcifications, dissections, coronary aneurysms? And is all of this dependent on this inflammatory reaction from the spike protein of the coronavirus?
That's a great thought because we're certainly seeing more venous occlusive disease in the COVID area. So I guess this is food for thought for us.
Right. More things to study, more things to develop. And we have a lot of young and upcoming interventional cardiologists, preventive cardiologists on the session. And I just challenge all of you all to take what you've learned from these great leaders and then use it, because we are now in a new world with a lot of new types of lesions that we'll be seeing. And so this conference is excellent to educate all of us, I think, and stimulate us to be better and better. This is the Olympic weeks, right? And so we're bringing all of the great gold medalists here for you all to learn and grow and develop and help the world.
Right.
So we
Thanks
really
for having us. Okay.
Thank you. Thank you very much. Now remember, we have 2 more days of excellent lectures.
You bet.
And I am speaking tomorrow, so everybody better watch that in the morning, and about external counterpulsation in the era of COVID-19 with all of the inflammatory problems that this is causing. So you may be excited to look at that. It's non-interventional, but I think you'll like it. And we have many, many, many speakers in Hall A, B, and C, and we just want to thank everyone for participating. Go and do all of your work, see your patients. We love you, and we'll see you tomorrow.
Thank you very much.
Thanks so much. That's terrific.
Thanks. Thank you. Thanks.
Thank you.